make it happen, but I had a lot of other things that I needed to do. In fact, one of the things we did during this whole period was we brought brilliant external people in, Paul Dighton on PPE, Kate Bingham on vaccines, and others. So the starting point is that building a plane in flight is harder than flying a plane that's been built for a while. And that is central, I think, to some of the areas where this country found it more difficult. Next thing is making sure that we had a system that was rigorous enough was critical. And we built that over time. And there were improvements that we had to make as we learned. So, for instance, one of the changes that we made in about September, October, was that if you were phoning somebody up on the contact tracing side to an individual, you asked them to tell their contacts in their household to isolate, instead of asking for the names of all those individuals and then phoning them one at a time. That change increased the efficiency of the system enormously, and was something that we had to improve. So when you build a huge system that I think Baroness Harding has said that it was about the size of Tesco and she built it in 6 months, there's constantly things that you have to learn on the way through. Whereas if you start with the system, then it's got all those teething problems ironed out.
So do you think, 5 months later, on the 7th of October, after it had been set up, Sage said that test and trace at that stage only had a marginal impact on transmission. At that point, and recognising that huge improvements have been made since then, but at that point, was that a fair assessment?
Well, I think that was probably at that point a backward-looking assessment, because by that point we had a very large system.
And it was a fair assessment of what had happened to that point.
It's Sage's assessment.
But is it yours?
No.
So you think they were wrong on that one?
I think that it had an impact, but it clearly hadn't had an impact big enough to bring R down from the R0, which is the R in the natural state of around 3, down to below 1. Now, there is evidence now, as of today, that the surge testing and the tracing and isolate system that we've got in place is working. If you look at the case rates now with the Delta variant, the places where over the last month we've put them into surge testing, starting with Bolton, but also true in Bedford, in Hounslow, and other places, their case rates are coming down.
I totally accept that, and it's fine to mention it, but I'm really looking specifically at why we didn't manage to stop a second and third lockdown. So I take on board what you've said. I just want to go through, if I may, some of the other reasons people have suggested as to why test and trace wasn't as successful as we'd all hoped. Now, you said earlier this morning that one of the reasons was that by the time we set it up, we already had around 2,000 cases a day, which is much higher than the levels that test and trace was having to cope with in Korea and Taiwan. So that simple scale was one of the reasons. Another reason that people have suggested is because people who were asked to isolate by test and trace didn't actually do so. Now, in February this year, Baroness Harding gave evidence to the Science and Technology Committee, where she presented 2 bits of evidence. One that said that 20% of people weren't fully isolating when they were asked to. Another that said that 40% weren't fully isolating when asked to. Do you have a more up-to-date number as to what numbers of people more recently are fully complying with the isolation requests?
I don't have an up-to-date figure. I'm very happy to write to the committee with whatever we have. I'm afraid I didn't prepare on topics on that topic. But what I would say is that we can see it working, and since Baroness Harding said that in February, we've done 2 important things. One is that we've strengthened the isolation payment so that in the targeted areas, anybody earning less than 26,000 gets their £500 isolation payment. So we've strengthened that element of it. And the second thing is we've increased the size of the isolation assurance service, which is the team of people who phone up and knock on the doors of those who are meant to be isolating to make sure essentially that there's stronger enforcement of isolation.
Thank you. And that's, I think, very welcome news. But I think the very specific thing we're trying to understand, because this is a lessons learned exercise, is why in that middle period of last year, we weren't successful in preventing the second and third lockdowns. And when Baroness Harding gave that evidence in February, we were in the middle of our third lockdown. Now, just on that point of financial support, some people say that one of the reasons people didn't isolate is because we didn't just give a simple promise that if you isolate because you're asked to by test and trace, we will make up as the state any salary loss that you have. Would that have helped?
Well, the challenge that we had with that proposal is the extent to which it might be gamed, because after all, a contact gives test and trace their contacts. That is what contact tracing is made of. And so you wouldn't want a situation in which you, if you tested positive, you could then list your entire friendship network who all get a £500 payment. So,
but that friendship network would be more reassured, and you might have been more willing to give their names if you had known that any salary they lost in the 10 days or 2 weeks they were asked to isolate was going to be made up. And just with the benefit of hindsight, I appreciate not all these things were known at the time, but is that something we should have been more open to?
Well, I think it's fair to say that I'm glad that we've made the change now.
Okay, I think we can interpret from that perhaps what your private position is. But I just want to go on because there were lots of other reasons that were put forward. And one of them was that we didn't have enough involvement early enough of local authorities in the contact tracing side. And indeed, some people argued in the testing side as well. Now, we know that they've been very involved recently, so I don't want to use the recent examples. This is simply about that period in the middle of last year. But knowing what we know now, do you think there is an argument that someone is more likely to comply with an isolation request if they're called up by someone locally who can then potentially check up locally rather than someone in the call centre 300 miles away?
Well, of course, and the fact we've changed it to have that dual approach is testament to what I really think now, because I think that is the best way to do it. But if I can just explain for the record, since this is a lessons learned exercise, some of the reasoning. So you have to have the national and the local system. And we know that because internationally, where systems are local only, we know that when there's a serious outbreak, they get overwhelmed. So I remember distinctly a phone call with my Spanish opposite number, in which I said, and tell me how your test and isolate and tracing system's going. He said, oh, it's terrible. It's fallen over in, and then he named a number of parts of Spain. And I said, and what about the national system? He said, no, we have no national system. So in countries that had only a local system, they pined for a national system. In this country where we had an essentially national system at the start, the critique was you need more local engagement. The honest answer is you need both. And this comes to data flows. Data flows have been strengthened enormously in this last 18 months. All the way through from the dashboard that the Prime Minister and I look at most days on what's happening, through to the management information that the department has about the whole health and care system. You'll remember from your time in the department that getting data out of the NHS used to be a huge struggle, and we now have common dashboards that we look at, making sure that there's free flow of data between organisations in a way, of course, that protects privacy, but allows for decision-making and allows for targeted activity, for instance, between local and national. This is absolutely critical. It's been improved no end, but by God, was it a problem at the start? Absolutely it was.
Okay, but I think we can understand now that you would need some national contact tracing capacity for surge capacity. But would you say, looking forward, that the primary engine of contact tracing should be local with national surge capacity ready to step in when necessary?
I think that's simplistic. So the way that we've tried to optimize it is not just according to surge and therefore the scale of need, but also according to those who are being contact traced. There are some people for whom a national call center system is the easy way of most efficiently gathering the data quickly and then acting on it. So speed matters here, and a national call center system can be much faster. And then you need the local boots on the ground, especially for the hard to reach cases. So what we've put in place is a system that is as smart as it can be, and it's improving all the time on optimizing which case and which positive goes through the local system, which goes through the national system, and when. So if you can't reach somebody after a number of calls, then it gets switched to the local system and they can send somebody around to knock on the front door. But you wouldn't put all contacts into the local system straight away, because you need to essentially deal with the easy to reach, which can most efficiently be dealt with nationally. So it's about optimizing a joint system with data flows that are unhindered and a team who work together cohesively. That's the way that I think this is best done.
Okay. And then just a final reason that some people say we may have still had those very large numbers of people who weren't isolating when we need them to, which meant that we couldn't prevent those second and third waves, is that perhaps, again, looking back, we were shooting for the wrong target. The whole system during last year was geared around testing targets. First 100,000, then 500,000, then 1 million. And sure enough, if you give a big system a target, ultimately they hit it. But shouldn't the real target in a pandemic not be a process target like testing, but actually the proportion of people who you need to isolate, who actually do isolate? Do you think, looking back, we hit the target and missed the point?
No, because we absolutely had those targets for the number of people who isolated and the number of people who we successfully contacted. We publish as much of that data as we can. The challenge in running a very large system is that if you have a target that is only indirectly reachable, you also need goals on the way that are process targets that are measurable. And so the answer is both. And if you think about it, just one more comment on this, we learned a huge amount from this experience that I've just described of improving the contact tracing and testing system for the vaccine rollout. So on the vaccine rollout, we have local and national data integration. We have the local systems going and finding people who are hard to reach. We have the national system for the big numbers of people who are enthusiastic and willing to, drive and queue up. And that integration is something we actively took from the learnings from the test and trace system and ensured that it was embedded in the vaccination system from the start. So, we've been doing our own lessons learned all the way through this. And one of the lessons is this data integration and ensuring that you get the right activities happening at the right level.
Thank you. Great luck.
Thank you. I'd like to go into a bit more detail on the question of care homes. We know, and I think we've agreed already this morning, that the decisions, especially in the early days and months, are taken in a kind of fog of war. Urgent decisions have to be taken without all of the information. But that fog is dispersing and some things are becoming clear. And I think it's fair to say that during this inquiry, we've established pretty clearly that we were too late to lock down sufficiently vigorously. And that many people, Sage, Dominic Cummings, yourself, everyone agrees that if we'd either known more or perhaps acted earlier, then that would have been better. I think we've learned that. And we've also established that we had inadequate testing capacity during the early phases of the pandemic. Both of those prospective conclusions, ones that you would agree with?
Well, I think that I absolutely agree that if we'd had that greater testing capacity at the start, of course it would have been better. But I'm a practical man. We didn't. My job was to build it, not just to feel sorry for myself that we didn't have it. We had to get on with it.
Absolutely, and we want to be practical and to learn lessons that can be applied in future. So what I want to establish here is whether we should add a third of these lessons, which was that discharging infected patients into care homes was, and for many perhaps understandable reasons, was one of the major faults in the first steps to handle the pandemic. You said, Secretary of State, right from the start, we've tried to throw a protective ring around our care homes. What was that protective ring?
Well, I think the most important words in that sentence are that we tried to.
Mm-hmm.
It was very hard. And all of these deaths in care homes, each and every death in a care home weighs heavily on me and always will. And we knew from the start, from very early in January, that the impact of this disease was most significant on the oldest, and therefore care homes were going to be a particular risk, care home residents. And this was a problem that we had across the whole of the UK, and indeed there were some other countries that had a really difficult circumstances. And so we put in funding. We made sure PPE was as available as possible. It was a challenge because we didn't have a distribution system. We had to build one. And we set out guidance for care homes. First guidance was on the 25th of February. And then later, when we had the testing capacity in July, we brought in the weekly testing of staff, which is, I think, the single biggest improvement in terms of protecting residents. And now, of course, we put care homes, both the staff and residents, in the top priority for vaccination. So that's what I meant, but it was very hard for a number of reasons, some of which are fixed and some aren't. So as I am Secretary of State for Health and Social Care, yet at the start of this pandemic, the powers I had over social care were extremely limited. The formal powers rest with local government, and formally social care is a responsibility of local government, but I feel it keenly. We didn't have the data. When I first asked for a list of all of the elderly care homes, we didn't have one, which I find totally extraordinary saying, but it's true. We simply didn't have the levers, and we had to invent a whole series of them. We now have far better data. But some of these problems still need to be fixed. We need to reform social care, and we need to make sure that we put into law the ability of national government, where necessary, to come in firmly to whether it's to issue guidance or that's binding, or put in place funding, because we had to funnel funding indirectly through local authorities as well, because we had no virus to fund local care homes directly. So there's a whole series of things that have been improved, and then there's a whole series of things that we still need to do.
So let's go into some of the decisions and to know whether you did have levers yourself or whether you were denied them. We know that on the 17th of March, NHS providers were instructed by NHS England, and I've got the letter from Sir Simon Stevens to all NHS trusts, ordering them to urgently discharge all hospital inpatients who are medically fit to deliver.
Yes.
Obviously a very famous instruction.
Yes.
Was that a unilateral instruction on the part of Sir Simon Stevens and his colleagues at NHS England, or was that, as it were, a kind of co-decision that he took with you?
No, of course, that decision was discussed with me and the Prime Minister before it was executed. And if I take you back to the time, we just had the scenes from Lombardy showing what happens when a health service is overwhelmed. We knew that the death rate would increase dramatically. We didn't know how much, but dramatically, if NHS services were not available. And we needed to make sure there was NHS capacity, because the number of cases was going up at the time exponentially. So we protected the NHS. And one of the things in the lessons learned exercise, which is really important for us all to remember, is that whilst there were absolutely challenges in some areas, there were some things that this country got right. And the provision of care at all times to COVID patients is one of them. Now, that instruction actually led to a reduction in the number of people who left hospital and went to care homes, because the vast majority of people went home to their own homes and we put in place social care packages. Because one of the other things that we did as part of that decision was we agreed to pay for the discharge. So in normal circumstances, when you leave hospital, the local authority has to arrange the social care package, and sometimes individuals have to pay for that, and sometimes the local authority does, as you well know. Because the central government, through the NHS, decided to, and the Treasury provided the budget to pay what's called discharge to assess, to pay for those discharges. It meant that we could get discharges, more of them, to people's own home. And in fact, one of the reforms we need to make to social care is that more people should be discharged to their own home with a care package as a proportion than into care homes. So the result of that letter, ironically, and I know it's counterintuitive, the result of that letter was a reduction in the proportion of people who were discharged into care homes. Now, I'm sure we'll come on to the testings around them, and in fact, we've already discussed it to a degree. But yes, that letter was a policy that was agreed at the highest level in government.
Absolutely, and that's very clear, that's very helpful. And you've also said in that answer that the motivation was a concern, looking at Lombardy, that the hospitals might otherwise be overwhelmed, and that galvanised the action that was a reflection.
Yes, but I don't want to imply, and it would be wrong to conclude, that that's because we somehow favoured the need to protect the NHS. Because as well as the scenes from Lombardy, I still remember, and it's burned across my soul, a news report from Spain in which the military were sent into care homes. And in one particular case, the care home had been abandoned because the staff were ill, and all of the residents had died, all of them. And many had died from COVID, but many had died because they needed care in order to live. And there were care homes in France where every resident died as well. And so this was a problem that everybody struggled with, and we talked about it amongst my colleagues across the continent, and of course with my fellow health ministers across the UK, how best to protect the most vulnerable. And in fact, in England, the proportion of people overall who died, who lived in care homes, is lower than in many European countries. So yes, this was incredibly difficult, but I think it is. You've got to look at the whole picture, and the number one fact, if you like, that matters in this is understanding how COVID gets into care homes.
Well, we'll come on to that, but the motivation you said was to certainly protect the NHS and avoid a Lombardy situation, but you've been very clear that that was not did not mean that you were unaware and unconcerned at all about what was
on the contrary
to care homes. You've said that very clearly. So is it the case that when you had that discussion with the Prime Minister about what I guess was the proposed advice from Sir Simon Stevens at that point, were you clear that the testing capacity to test people leaving hospital going into care homes would not be there immediately and for at least a number of weeks?
Well, I don't recollect directly, but I know for a fact that the testing capacity at that time on the 17th of, well, the letter was, I think it was dated 17th of March. Well, I know at that time that the testing capacity was around 1,000 a day, because the 17th of March was the date on which we had the cabinet room meeting where I took direct personal charge of the testing.
So you knew that there wasn't the capacity there to do it, but did you communicate that to others that were part of the discussion about this new policy?
It will. I'd be amazed if that wasn't part of the discussion. I haven't seen the minutes of that discussion recently. In fact, I don't think I've ever seen them. But but I know that it was agreed and signed off across government. There is no doubt that the testing capacity would have featured, but also remember that the clear clinical advice at the time was that testing people asymptomatically might lead to false negatives, and therefore was not advised and was seen as a not a good use of the precious few tests that we had at that moment.
I mean, this is an important point of contention in our last evidence session, as you know, because the evidence that we had from Dominic Cummings was that people in that meeting felt assured that the testing capacity would be in place. Now, at the opening of the session, when I put this to you, you said you were always clear in your mind, and as far as you know, the way that you communicated this, that you were talking about a plan to get to that capacity. Thinking back, was there any possibility for ambiguity there? Do you think in that discussion, you could have thought you were talking about future capacity, and people like Dominic Cummings, and we don't know what the Prime Minister thought, but could they have thought that it was available now?
There's two responses to that. The first is, you've got to remember that we were taking huge decisions under imperfect information and against a completely unprecedented situation. And the recollection I have is that at that time, the clinical advice was clear. And in fact, I checked this with the Chief Medical Officer in the last couple of weeks, that this was his recollection as well. And the recollection was that the clinical advice was against asymptomatic testing for the reasons that we set out, and for the clinical reasons that I've reported to the committee, but they weren't my reasons. They were the clinical advice.
In terms of a misapprehension,
we didn't I have no.
But you were clear in your mind that the capacity wasn't there, and so it would have been strange for people to assume that it was.
That's right.
But you don't have any kind of positive recollection of others that were part of that discussion conceding and agreeing that.
I don't have any recollection one way or the other.
Now, again, in the evidence that we heard from Dominic Cummings, he said that when the Prime Minister returned from his illness, in other words, in April, he came back alarmed at what was going on in care homes and asked, what's happened with all those people in care homes? And Dominic Cummings said he used a less polite version of, what on earth are you telling me? Did the Prime Minister, when he came back from his illness, did he have a conversation with you that indicated he was surprised to find out what was going on in care homes?
Not that I can remember.
I see. And in terms of the numbers here, in your initial answer, you talked about the numbers. How many people were discharged before testing was available for people being discharged?
I don't have that figure with me. I think it's in the public domain, and if it's not, I'll get you the best estimate that we have.
Right. I think the NAO says it's about 25,000. You presumably
I wouldn't dispute the
you wouldn't
NAO's
dispute the
figure.
NAO. That reflects your feeling.
I wouldn't dispute that figure.
Okay. Now you did say that the number of discharges actually going into care homes fell compared to the previous year. I think I remember you saying that.
The figure I actually used was that the proportion of discharges fell.
The proportion. And is that from that NAO analysis? Is that
that's from an NHS analysis that I think we published at the time. But if we haven't published, right, then I'll make sure we.
Well, I think it is the same analysis, and that talks about a period between the 17th of March and the 15th of April. But it misses out a crucial period at the beginning of March, in which it was the case that actually the number of people being discharged from care homes was higher than it was in the year before. Were you aware of there being an escalating problem that required you in the middle of March to put the brakes on it?
Well, I wouldn't be surprised, but the recollection I have of that chart, if you like, of that data series, is that it was essentially flat and then fell. the proportion of people who were discharged into hospital. And you can see a clear policy reason why that would change on and around the 17th of March, and that's because we put the funding in to fund the NHS to buy the care packages, which are more likely to be the care packages in the people's own home. But I'm sure that we'll go through the full detail of exactly what those numbers are.
So in terms of the steps that were taken, you said that the transmission into care homes was not predominantly from people coming out of hospital, but it was from staff. Is that right?
So Public Health England have made a recent publication of this, and they've found that approximately 1.6% of the cases going into care homes came from people leaving hospital. And there's two reasons that it might be so low. The first is that, of course, there were infection prevention and control, essentially isolation rules around how people went from hospital into care homes, because of course they were not tested, because the testing capacity wasn't there, and the advice was not to test for the reasons that I've set out. And therefore, there was already an isolation process in lieu of knowing whether somebody was COVID positive or not. And anyway, if people were COVID positive, there needed to be an isolation arrangement for them. The second reason is that just in terms of the numbers, the proportion of people who go into a care home is much, much higher each day from staff. That's inevitable in any care home. The number of people who are residents who move in and out of a care home on a daily basis, even in normal times, is a fraction of the number of staff and indeed other professionals like like GPs and other health professionals. If you think about a care home and who physically goes in the door, the number of times that person going through the front door is a resident is really quite a small proportion of the total. So I do understand why people feel very strongly about this point of residents going into care homes, but in terms of the volume of human movement and interaction with a care home, you can understand once you think of it that way, because this virus transmits between humans of whatever type, whether you're a staff member or a resident, the virus doesn't know or care. It's therefore the staff testing regime that was the big change that we brought in over the summer, and then we learned all of these lessons and did a review with the care home providers and CQC and others, and came up with the care home winter plan. And so in the second peak throughout the winter, the proportion of deaths that we've had in care homes is far, far lower. And that is that's one of the many lessons that we've been learning as we go through this.
Well, let's go on to the staff transmission in a second. But on that Public Health England report, which I've read, essentially it relates a positive COVID result in a care home to whether that person has been in hospital before. That's the way that it's, they call it a data linkage approach. That's the way they approach it. That's right, isn't it?
Well, the methodology is the best methodology they have. It is a difficult figure to put a number on.
Yeah, but it's made more difficult, is it not, by the fact that people weren't being tested in care homes, and therefore the chances of finding someone with a COVID positive test and then linking that back to a discharge from the hospital is very low indeed, because the whole point that we've been discussing is that testing was not available in care homes. So isn't it, to put it most politely, a stretch of the imagination to believe that 1.2% of cases, 1.6% of outbreaks are attributable to hospital transmission into care homes, when we simply don't have the data because people weren't tested there?
Well, it brings me back to the central point about the challenge of responding to this pandemic, which is that we were having to make these judgments, sometimes very big judgments, based on imperfect information. Absolutely. And getting better information is vital. Now, I think that that study is the best assessment that can be made, given the fact that the facts on the ground in terms of what is and isn't measurable. So it's always a challenge to measure these things.
It is.
And estimates are estimates. I think I described it as an estimate rather than a fact, partly for this reason. However, once you think about the number of people who go into a care home and think about that in terms of staff and residents, you can see why that a figure of that amount or might be appropriate. There are reasons to explain it, but anyway, that is the best estimate that we have. But of course, it remains an estimate.
That's a bit of a danger for a lessons learned inquiry for us and for you and colleagues in government in the department, because that study was a look back at what happened during the period. It was an attempt to learn lessons, and you drew a pretty important conclusion, which was that infections from hospitals was a small, in fact, a tiny proportion of deaths in care homes. And that conclusion then has policy consequences, very important policy consequences for the future, to look, for example, at staff transmission rather than so much hospital transmission. But it's not possible. We don't know what the answer is, because people were not being tested in care homes. So it's completely impossible to say that less than 2% of infections in care homes were attributable to hospitals, is it not?
No, because firstly, we did test in care homes throughout when people were symptomatic. And then we brought in the Vivaldi study in care homes over in the late spring, after the first peak, but nevertheless, we brought it in. And so this isn't based on no data, it's based on the data that we had. But I keep returning to this point that you're working on imperfect information. I also disagree with the idea that because that figure is low, therefore it shouldn't matter. It does matter. Each one of those infections matters. And so absolutely the discharge protocols, which require now testing and isolation in lieu of until there's a comprehensive test result, of course that matters.
But the care home providers are very clear. We all know that there was limited testing in care homes. Yeah. So to attribute the deaths, the positive cases in care homes to hospital discharges without a representative study can't have the weight that you're placing on it. We don't know, and it's important that we do find that out. No?
Well, of course, it's important that we find out as much as we can. Mm-hmm. But there are some things about that first peak that we'll never know, right, because we didn't have the information gathering capabilities that we have now. So it's a but I also I will also argue, and I'll always believe this, that it's best to make your best assessment of these things, even if you have to recognize that these assessments are imperfect. I mean, the search for perfect information in a pandemic is a vain one.
Indeed, we should therefore open these things up to scrutiny.
So absolutely, like publishing the PHE report so that the chairman of esteemed select committees can read them.
Quite so. And has it been peer reviewed?
I don't know.
It would be normal for an important publication like that to be peer reviewed.
I'm sure it says it on the top of the document, but the
doesn't even say who the authors are.
Well, I will. I'll go back and find out if it's peer reviewed. But we do. Look, we've also, there is a different approach, a different principle that in a slightly different part of the forest. There is far more pre-peer review publication now, because you have to get the best information you have with all of the caveats, including the ones that we've discussed, out into the public domain, right, rather than waiting for perfect information which may never come.
A final question, which picks up on the point that you made about the possibility of infection from staff, social care staff in care homes.
Yeah.
you recognise that as an important potential source. But obviously the weekly testing of staff was not announced until July.
Yeah.
I think was rolled out from July onwards.
Yeah.
Obvious question, why, if that was thought to be the prime way of infection getting into care homes, why was it not possible to do that earlier?
Well, again, this comes down to the prioritisation of tests.
Right.
And
so you went as far and as fast as you could, given the testing capacity.
And given the clinical prioritisation of the use of tests, yes.
Right. So in essence, what you're saying is that this question of infections within care homes comes from a combination of an understandable and perhaps necessary requirement to avoid a Lombardy situation in the NHS, combined with what we've previously talked about, which was an inadequate testing capacity. That is, that they're the components of the problem in care homes as you see it.
And a presumption that testing people who had no symptoms would lead to false negatives, which turned out to be wrong, but was the clear clinical advice for some time until we had a better assessment of that in April.
Thank you very much.
Thank you. Dr. James Davis.
Thank you, Chair. Thank you, Secretary of State. I'd like to return, if I may, to the success of certain countries in South and Southeast Asia, so South Korea, Singapore, Taiwan, and so forth. We've already touched on their pre-existing testing capacity. Were you given advice not to follow their strategies in other respects?
No, I don't think we were advised not to follow their strategies, but I can't remember being formally advised to follow their strategies. But we did have discussions. With them.
Mm-hmm. And in retrospect, you would agree that there should have been more focus on what was going on in that part of the world and their success?
Well, there was a huge amount of focus on what was going on in China, although one of the things that hindered our early response was a lack of transparency from China, and that must be put right in terms of future preparedness for future pandemics. It is absolutely vital for the world that China is more transparent about its health information as soon as it understands that there are problems in future. With respect to the rest of Southeast Asia, I think that we would benefit a lot from ensuring that our future pandemic preparedness learns from the other, from different strategies that were pursued right around the world. The strategies different countries pursued, in my view, followed essentially two things. One, their recent history, and the countries that obviously had, it's standard now to say that the countries that had experienced MERS and SARS were better prepared, partly because their body politic had a shock a decade earlier. And here, that shock in around 2009 was not heeded as much as it should have been. The second is in terms of their capabilities and to an extent their geography and history. So it is harder in a democracy to take some of the steps that some of the authoritarian countries took. Geography matters. So Britain is an island, and we have the benefits of being an island in terms of borders, but we are a highly interconnected island which has a tunnel, and a huge amount of our freight comes accompanied. So other islands like Australia, New Zealand, Taiwan were able to be more absolute at the border, whereas completely shutting the border here is not something that we are structured to do, because I think a very serious chunk of our daily imports comes accompanied, and then of course this history is also about the capacities you have at home, and we just didn't have the testing capacity in particular, and the contact tracing capacity that others had.
We didn't have the capacity, but was it discussed that British people wouldn't accept East Asian testing and tracing methods?
Well, there was a debate about how much people would accept it, but I was always of the view that people would go for it. And my view on the use of data was that because the mission and the motive was so important, people would be willing to allow their data to be used because and give consent to that because the justification was so clear. You know, the story that I told at the time is, you know, over 95% of people are willing to give their iris scan to the Home Office in order to have a queue that's maybe 5 minutes faster at the Heathrow when they go on holiday. And if you're willing to give your biometric data to the Home Office, you're likely to be willing to allow your data to be used to save lives and try to stop a pandemic. So my view on the public's approach to consent for their use of data for these purposes is that my experience is that they are very enthusiastic so long as there is a proper mission and there was a clear mission here. So I was up for action in this space. I personally didn't think that would be a problem so long as we articulated it properly, we got all the privacy rules, etc. right.
Mm-hmm. Now, Dominic Cummings alleged that there was a lack of urgency in our approach to the pandemic in February and March because we believed ourselves to be lower down in the pandemic curve. He also said that the implementation of measures was delayed because there was a lack of planning and preparations in place. And how would you respond to those 2 points?
Well, the first is true and the second is false. So it's absolutely true that we thought, and the advice we had was that we were earlier in the pandemic curve than our European neighbours, and we were, as it happens, we were seeded. The virus, we now know from genomic testing and the huge genomic testing capability we now have, that there were thousands of individual incursions right across the UK. So we didn't have an outbreak in individual areas. We had an outbreak essentially everywhere at once. And that was one of the reasons that we had a tougher first wave, along with frankly, the fact that the population isn't as healthy, and we know that obesity is a significant risk factor. So that was true. On the second point, the idea that we didn't have a plan, the evidence I can best point you to is the fact that we had at that point published a plan.
Okay, fair enough. Finally, from me, in terms of face coverings, now SAGE discussed in late April the fact that there was some evidence, albeit weak, for the use of face coverings. Then I think on the 11th of May, they had issued advice for their use in enclosed spaces. Then the UK government mandated their use on the 15th of June in public transport settings, 24th of July in shops, 24th of September elsewhere. For the record, in Wales here, that was 6 weeks later, I think, for each change. But why was there a delay, first of all, in implementing what SAGE was advising, and also why were we as a country as a whole perhaps behind other countries in the world?
Well, there was a rigorous international debate about the use of face masks, and there were very significant divisions in the science on this. And I think that it is one of the clear lessons from the pandemic. It comes down to disagreements about the most likely route of personal transmission of the virus from one person to another, and there is now a common understanding much more about aerosol transmission from one person and how face masks are therefore more important than was the initial advice. There is also a practical consideration that we didn't want people to take face masks away from where they were absolutely vital within health and social care settings. And so when we did introduce rules around public's use of face masks, we introduced them saying that you should wear a face covering, as many people in this room are, because that way it didn't take away from the provision of PPE. Now that isn't a problem. We've got huge stockpiles of it, but it was a problem at the time.
Thank you, Chair.
Anam Kaiser-Javid.
Thank you, Chair. Thank you for joining us today, Secretary. So whether it's policy implementation or the general workings of the UK government, or even in your role as Secretary of State for Health, public trust is of paramount importance. Getting those key lines right, ensuring that communication is clear and maintaining that trust so that the general public have faith in the leadership of the country. Would you agree with that statement?
I very strongly agree with it, yeah.
So then why during the pandemic do you think that the Prime Minister had lower approval ratings in comparison to his counterparts of devolved nations?
Well, I don't think it's about approval. I think it's about, as you say, public trust. And we worked very hard to ensure that we had the support of the public. And in fact, when you look at the proof point of that, the consequence of that, the public have been incredibly strong in supporting the measures that we asked them to support. And ultimately, that's what you need the trust for. And then perhaps the most important factor when it comes to having the trust of the public is to make sure we get very, very high vaccination uptake. And we've got extraordinarily high vaccination uptake. That is, and that's true across the whole of the UK. In fact, I think it's stronger in some parts of the UK than others, but this isn't a competition. It's important that that's high everywhere.
Okay. But going back to that idea of how the public view their leadership, that is something that is taken into consideration, whether that's by the media or by government or by other members of the public. In November, an Ipsos Murray poll found that 74% of the Scottish public believed that Nicola Sturgeon had handled the pandemic well, in comparison to 19% who thought the same of Boris Johnson. Now, there could be differences there because the NHS in Scotland is devolved and there's NHS Scotland. But what lessons do you think the UK government are learning in terms of their communication?
Well, I don't have the latest figures on me, but I noticed that to prove your point in your question, you picked figures from November. And I've already said that I think that the operation of government has improved very significantly since November. And the public have definitely noticed that. And in fact, the public trust across the UK in the measures that the government have taken has increased significantly. I've noticed as Secretary of State that it is now more efficient, more effective, there's better communication inside of government, there's a better sense of teamwork, and that is so important in a pandemic. And the public have undoubtedly noticed this improvement over the past 6 months or so.
Do you think that the public trust you?
Well, I think
Secretary of State?
you can judge that. You can judge that for yourself. And
I'm asking you, what would you?
Well, I think all I can say is that the approach I've taken throughout this is to try to answer questions as directly and straight as possible. I'm a big team player. I'm willing to say difficult things if necessary. And that is I think the best approach you can take in the pandemic, answering difficult questions and answering the questions that are easier to answer. You know, when difficult things happen, my approach is to go to the dispatch box or have a press conference and explain why there's a difficult thing. And I think that's important in a pandemic in particular. But at the same time, I'm a huge team player, and I think it's very important that we operate as best as we can as a team.
Yeah, and I completely agree with you. Team player and ensuring that all 4 parts of the UK are heard loud and clear. Rewinding back at the session that we had with Mr. Cummings a couple of weeks ago, he claimed, whilst I was questioning him on borders, that the Prime Minister in the UK government prioritised the economy over people's lives. Now that's quite a damaging allegation, but that allegation was made. I'm not going to question you on the validity of that, but what I'm going to ask you is, statements like that have been made, what actions are the UK government going to take to maintain or regain trust from the public?
Well, the honest truth in response to that is that we have some of the toughest border measures in the world. and people can see that we're willing to take difficult decisions on borders based on the data, if that's what's needed. So for instance, just last week, we had to remove Portugal from the green list of countries, despite the fact that that was very uncomfortable. And there were lots of people who were, especially who were on holiday or out in Portugal on business, whom that had a significant impact on. But when the data changes, then we are willing to make those difficult decisions because we have a tough approach at the borders.
And you think those decisions are made in a timely manner?
Well, absolutely, yes. In fact, when we took Portugal off the green list, I was criticised for acting too quickly. But when you see a new variant, then it's incumbent to act.
Okay. Many ethnic minorities during the COVID pandemic have sadly passed away. What steps did your department take to engage in those communities who, for example, maybe have English as their second or third language, or traditionally don't engage with the NHS?
Yes, this is incredibly important throughout. To be honest, I think it's something that we have got better at. We've got better at working alongside local authorities in terms of engagement, and we've taken those learnings, a lot of which we learned through the use of the testing program, and deployed them in the vaccination program. And although the vaccination rates now are lower for some ethnic minority communities, we are seeing those rates rise up, which I'm really, really pleased about.
Sorry, the question I asked was what steps did your department take? So yeah, you're saying you worked with local authorities.
Yes.
Anything else?
Yes, huge amounts of work. I mean, so for instance, the Minister, Nadine Zahawi, on the vaccine rollout has undertaken a huge amount of work over the last 6 months in terms of engagement with communities of all sorts across the whole country, whole of the UK, to make sure that we try to get the messages across. For instance, ensuring information is available in the language that people commonly use is so important. And from a point of view of the attitude that we take, some people say you've got to do better at reaching hard to reach communities. I don't think about it like that, because that implies that somehow it's their problem. It's about making services more accessible to people and making sure that we make it as easy as possible to access services. Because I'm pretty sure that you've got to make sure that you reach out. So that's been a big part of the plan all along. Okay,
and just one last question. So Mr. Amjad El-Hilrani was an ENT specialist at University Hospitals of Derby and Burton, and died on the 28th of March 2020, and he was the first doctor to die due to COVID, and a lady called Nasreen was one of the first nurses to pass away, sadly. And you're sitting here with your NHS badge on. It was one of the first things I noticed. Do you think NHS have trust, or NHS staff have trust in yourself and the government in the way that you've handled the pandemic, and will lead us out of the pandemic?
Yes, I do, and it's something I put a lot of effort into. And right across the UK, making sure that the health services we provide are there for everybody is incredibly important to me. And the NHS across Great Britain is our most valued institution. And the people who work in the NHS work incredibly hard and have faced some of the toughest situations of their lives over the last 18 months. It saddens me enormously that around 1,500 people from health and social care lost their lives in this pandemic. And I know, in fact, I know that the first 4 doctors who lost their lives were all from ethnic minority communities. In fact, I went at Eid, I went to Brent Central Mosque to thank them, and through them, everybody who works in the NHS from all different communities, and especially to mark the sacrifice of those who've come to this country to offer their services and to work in the NHS, and who gave their lives in that service during the pandemic. It's something that's moved me a lot.
So would you say that you protected the NHS staff?
Absolutely. We did everything we possibly could. And not only that, but we protected the NHS, so the provision was there for patients as much as was possible. And we provided that, the PPE, as we've discussed, and we worked together right across the UK, including with the Scottish Cabinet Member for Health, Jean Freeman, who I worked very closely with, to make sure that everywhere in these islands, people got the support that they needed and the treatment that they could as much as possible.
And Secretary of State, in the Chamber on Monday this week, you said that nobody was denied treatment for COVID. People got the treatment they needed. You repeated that earlier.
Yes.
I'd just like to draw your attention to two things. First, the widespread reports of the use of do not attempt resuscitation notices, which I know has been challenged,
Yes.
but was widely reported both last year, this spring, and is reported again today in the Telegraph in terms of people with mental illness and people with a learning disability. The second point is the refusal of some hospital trusts to admit COVID-19 patients from care homes. Bearing those two things in mind, are you really still saying that everybody with COVID-19 got the treatment they needed?
Yes, that is the medical advice that I have, and I totally agree with you about the inexcusable nature of any attempt to use do not resuscitate orders without consent. And when there were concerns raised at blanket consent being put in place, we stopped that immediately. So yes, I mean, making sure that provision was there was absolutely critical, and we did succeed. It wasn't just, it wasn't me on my own. It was a huge team effort that everybody was involved in, because part of the action that we took to suppress the virus was in order to protect the NHS. If you think about it, my strategy through this was to suppress the virus until a vaccine could make us safe. And I always believed a vaccine would come through, and I drove that project hard. But yes, the clinical advice that I have, and I checked again on this recently, as I said earlier, was that provision was always available.
But I had cases of this happening to a constituent of mine. I had a case on April the 3rd of a constituent in a nursing home. Her daughter was contacted out of the blue by an NHS hospital staff member who told her that her mother would not be admitted to hospital if she contracted COVID. Now, that was a battle that I took up on her behalf with the local hospital. But my constituent said this: my mum's life was made insignificant because she is old and has had dementia. Now, I understand from a colleague that this also happened in Hove and Portslade, and as I've said, it's still being reported. In my view, this was a serious impact of the policy of discharging patients from the NHS to care homes. In my view, it led to a mindset in parts of the NHS that it was okay to deny treatment to vulnerable and older people. Let me ask you, were you aware last spring that some hospitals had gone out to care homes and told them they wouldn't be admitting their residents?
I immediately insisted on the issuance of very clear and strong guidance, which is that this approach is completely unacceptable. It's never been acceptable. It's never been a policy. And when I heard reports, and in fact, you've raised reports with me of this before, I immediately took action to reiterate the position that do not resuscitate notices require informed consent. There are proper procedures around how you can go about giving and recording that consent, but individual decisions must be made on an individual basis.
Indeed, I really want the question though, why we kept having reports, why this kept on happening, why there were patterns of this happening up and down the country, and we're still getting reports of it. There've been a couple of surges of reports of do not resuscitate notices for people with learning disabilities, and the Telegraph includes today reports of people with mental illness. It certainly happened in parts of the Northwest. for people in care homes, and that was reported to me, and I've reported it in the House. Why were questions not asked about a policy with such wide-ranging impacts on vulnerable people? I understand it's been challenged and you put guidance out, but it kept on happening.
Well, the guidance we put out was absolutely crystal clear, and this, the idea that a DNR notice should be put on without the individual consent process and the individual knowing what, being able to, the correct decision being taken with clinical advice on an individual basis it is completely unacceptable for the guidance not to be followed. And in a system as big as the NHS, it is very important that when people see problems like this, then they raise them and then we can address them. But the availability of treatment was always there. Treatment was available for these people in all circumstances, because we never ran out of that capacity, in part because of the action that we all collectively took.
You're not willing to accept that from these reports, and in fact, for myself as an MP, that this was happening, that there was a denial of treatment to some people. I understand, and I've said that you challenged it, but the problem is it carried on happening. Well,
I have seen these reports, and it's totally unacceptable.
How can you stop it though? It's not as if it just happened once.
The strongest thing I can do is ensure that the NHS issues guidance to make the rules around this absolutely clear, and that is what I have done. The point about protecting the NHS is that the capacity to treat all people for COVID was always there throughout, even in the highest peaks. So that treatment was always available at all times. And I'm very proud that we managed to build that capacity. And in fact, the NHS themselves did a remarkable job in building the Nightingale hospitals, for instance.
Yeah, it's not about that though, Secretary of State. It's not about that. It's about a cast of mind, a mindset that treated vulnerable people, people with learning disabilities, people with mental illness in a particular way. But let's leave the point now. I want to raise the question of expert advice to the government. You mentioned earlier clinical advice on testing on discharge to care homes, and you said it was advice from SAGE. I think you quoted that a couple of times. SAGE had almost 100 advisors, including experts from health, epidemiology, criminology, psychology, statisticians, environmental and behavioural scientists, but no social workers and no input from care providers. Care England told me planning prior to the pandemic didn't involve social care. It was all focused on the NHS. The Association of Social Work Chief Executive, Dr. Ruth Allen, said, SAGE would be strengthened enormously by input from social work, and it is shocking that we have none. Some of the biggest care home operators have said that they repeatedly warned in March 2020 about the dangers of discharging people into care homes without testing. And they warned both you directly by email and via representatives of Care England. Given the terrible excess mortality in care homes, partly driven by actions that the care sector had warned could be damaging, you recognise that this failure to include expertise from the care sector was a mistake?
Well, the way that clinical advice reaches me as Secretary of State properly is that the Chief Medical Officer, who co-chairs SAGE, listens to the scientific views, because SAGE is a scientific body, and then also takes into account the operational considerations from social care, from the NHS, and from others, and then puts an assessment and recommendations to me and to other ministers, including, of course, the Prime Minister and the Chief Scientific Advisor.
Do you think that advice was strong enough? Do you think that listening to the care sector was strong enough? Because I have to say, right through the pandemic, but particularly in the early stages, there was the view that care sector was being treated as an afterthought.
Well, I do think that we strengthened the way that we got advice from the care sector through the pandemic. And when we wrote the winter plan and published it, I think in August 2020, we took several weeks to ensure that we worked closely with the representative organisations of the care sector to make sure that winter plan was road tested with them in advance, learning as many lessons as we could. But
was in August. That was not in March, April, May, June, July. That was in August.
Thank you.
So well past the first wave.
Thank you. I was coming on to that. Before we had then over the summer the time to be able to write a draft and then to be able to circulate it, take on board comments, which is the normal way, of course, of developing policy within government. In the first peak, we were operating with these huge decisions based on, as I've said, imperfect information, but also at remarkable speed. We had to move very fast. So of course, we took on board views of the care sector and the experts on social care who we were engaged with, but we were not able to undertake the full public consultation that we normally would do with development of policy of this significance, simply because of the time that it took. And so, if you think back to those times, it was a matter of acting as fast as we could to keep people safe, and that meant that you couldn't go through the normal formal channels of consultation that you would for something obviously of this huge significance.
I think what's important, though, in terms of the lessons learned that we're trying to gather today, just the point about what impact this lack of knowledge about the care sector had on the decision making of the time. We had Professor Whitty say to the Health and Social Care Committee in July that the risk of agency staff travelling between homes and spreading the virus was not recognised early on during the outbreak. He admitted that in retrospect it's obvious, but it was not obvious early on, which really does show that there was no input, no listening, no expertise from the social care sector in that early stage, which was so important because, of course, decisions were being made that caused the excess deaths. Let me just remind you of this. My colleague Peter Kyle raised this set of issues in the House of MQs on the 25th of March, and he wrote a letter about it to the Prime Minister, and he copied you on March 31st. He described a care home in his constituency with a serious COVID outbreak involving residents and staff, making clear the staff who had COVID were agency staff who had been working in other care homes. I wrote a letter to you on April the 1st, jointly with John Ashworth, pointing out the lack of PPE in care homes, concerns about care staff unable to access tests, the need for testing for patients being discharged to care homes. I also raised the issue that care homes had said they were unable to transfer sick residents to hospitals due to a lack of beds, and that hospitals would not admit patients from care homes. Care England have told me that at the start of the pandemic, several care providers offered brand new care facilities that hadn't been commissioned and could have been used for the isolation of patients potentially with COVID discharged from hospital, and they received no response from the government. Having no expertise on social care in your group of advisors, why did you not heed the warnings about dangers to the care sector raised by MP colleagues, the care sector, and Public Health England?
Well, you didn't only raise these concerns in a letter to me, you also raised them with me in the House of Commons. And I think making sure that we got feedback from MPs who are expert in particular areas, including in social care, was a critical part of the response. And it led to us strengthening the guidance throughout. So in that period, after you wrote on the 1st of April, I think it was, we strengthened the guidance to care homes on the 15th of April. So we had the attitude, and I remember discussing it in the House of Commons, I think in an exchange with you, Chair, the other Chair, with the member for Tunbridge Wells, for the record, about attitude to listening to concerns and the need to constantly feed that into how we responded. I was completely open about that. And so you raised the issue of care homes in the House of Commons, and we took into account those concerns as we updated the guidance, but it was inevitably an iterative process because we were operating at such pace in the face of unprecedented circumstances.
Earlier you said on your discharge policy to care homes that Tests took 4 days to turn around, at which time a patient could have contracted COVID. But on the 11th of March 2020, the NHS said approximately 1,500 tests are being processed every day at PHE labs, with the great majority of tests being turned around within 24 hours. So that's 1,500 a day, with most turned around within 24 hours. And as I just want to reiterate the point, Care England has told me that several care providers offered the use of those brand new care facilities that hadn't yet been commissioned for use to isolate discharged patients. They received no response from government. Why?
Well, I wasn't aware of that letter, and on the turnaround times, what matters is
You
that
weren't aware of the, could you just be clear about this? You weren't aware of the offer from several care providers of care facilities that could be used to isolate patients, because that's actually pretty important.
Well,
in
I
terms of the
can't. I think
life and death.
a better answer is that I wasn't. I can't recollect that letter. And what I can tell you though is that the turnaround times sometimes were fast, but sometimes not. And if somebody is left in a hospital setting with when they've been tested, they can catch COVID. And
Yes, but
sending somebody into a care home with COVID with a negative test result is very dangerous.
You're repeating a point that you made earlier, and I'm repeating. Care England have told me that several care providers offered brand new care facilities that hadn't been commissioned and could have been used for isolation. So if tests hadn't come back within 24 hours, they could have been used in that way. Could be in a combination of prioritising care home discharges to care homes for testing, and if the testing hadn't come back, they could have gone as an interim step to those care facilities which were offered. Why didn't that happen?
Well, as I say, I don't have a recollection of that correspondence.
Well, that's you'll admit that that would have been a solution, though. And in fact, I think it was adopted as a solution later on in certain parts of the country that step down facilities were used from hospital. But clearly, I mean, we're talking about thousands of deaths here in care homes. This is important. You were taking clinical advice on your policies that didn't include advisors from the care sector.
No, that's not quite right. So I just want to correct the point there, which is that the clinical advice, the scientific advice from SAGE, because SAGE is the scientific advisory group in emergencies, is then combined with the operational advice from the department and others in the clinical advice that comes to me. And I know that might sound technical, but it is inaccurate to say that because SAGE did not have operational experts, that therefore that was not taken into consideration in the advice to me. SAGE is a scientific body, not an operational body, and that's how the advice is structured.
It's a scientific body on whose advice you were relying for the discharge policy into care homes. Leave it there. You don't seem to want to accept the points I'm making. I mean, finally,
well, I just want to give accurate answers. Can I also add that on the point about, I want to add a further point to my answer on the DNRs, because I think this is such an important point. As well as issuing the guidance, we also asked the CQC, who regulate the care home sector, to make sure that they reiterated this point. And if there are further levers that are available to stop people wrongly using DNR notices, then I'm absolutely open to it. But I have sought to use every power at my disposal to stop the inappropriate use of DNRs, whilst allowing people who want to express a wish that they should not be resuscitated to do so.
Indeed. Just finally, before we leave this point about the lack of expertise from the care sector, or operational knowledge, as you call it, you said earlier about the care sector, we didn't have levers, we didn't have data, we didn't even have a list of who the providers were.
Yeah.
I just point out to you that there are organisations like Care England and the National Care Forum that are perfectly capable of providing lists of providers, that are perfectly capable of advising the government. As I say, very strongly came across to me, both in my own constituency and nationally, that the care sector felt they were treated as an afterthought. And I think it would actually be advisable now to think about how to take their advice better into account so that we don't get into the decision making and the issues that we got to in this particular pandemic.
Well, absolutely, we were in contact with those organisations throughout, and indeed the CQC, but none of these lists are comprehensive, and this is the problem that we were facing, which we have now
You're saying that Care England doesn't have a comprehensive list of its members?
No, I'm not. No, I'm not. But
But we will definitely be making recommendations in this area in our report. So, Graham Straw.
Thank you, Chair. Can I just say, Secretary of State, I not always agreed with the decisions you've made in this area, but I do appreciate the number of times you present yourself onto the floor of the House of Commons and to these committees and other committees. Can I take you back about 2 hours, I would think, to Becky and Greg's questions, where they were asking about the information that they believed had not been presented yet when PHE changed their advice. Are you aware that a Dr. Cathy Gardner is taking the department to judicial review?
Well, the department is engaged in judicial review on a number of aspects.
Yeah. Because according to the Byline Times, which I think was what Becky was referring to, that report, you or the department via you had not provided the emails, advice and other information that had been asked for in that case. And I don't want to make a clever point, but if one was to apply to that lack of evidence the interpretation you put on Dominic Cummings, not supplying us with the supportive evidence, then we should be very worried. So will you provide all that evidence that's been asked for in that case and has been asked for by this committee to the committee?
Well, of course, I'm happy to provide all the evidence that I've committed as per the previous exchange. But I'd say this: my whole approach is to provide you with whatever evidence is needed for you to reach your conclusions, and hence being open to questioning for as long as you like. I mean, and I'll tell you why, Graham, and it's kind of what you said about me coming to the House throughout the pandemic. I'll tell you why, and that's because I know deep in here that what I did and what my team did was what we believed to be the best thing we could on the information that we had to protect lives and to get us out of this pandemic. And we worked every day from the moment we woke up to the moment that we fell into our beds on that mission for months and months and months. And I know that I can face the mirror each morning, and despite my deep regret at the deaths that have occurred, I know that I did that with the right motive, being straight with people throughout. And this pandemic has caused enormous pain, but the way through it is to try to bring people together as a team, which I hope I've demonstrated, and be as transparent as possible.
I don't doubt your motivation, Secretary of State. I don't agree with some of the decisions you've come to. The membership of SPI-B have given an apology for their advice. They said that they regretted having given extreme advice, and they thought that behavioural psychology had been undermined, that they had given too much bad news and not enough good news. And Gavin Morgan said he thought they'd not behaved ethically in doing that. Do you accept that apology, and do you accept any responsibility for the negativity an unethical nature of that advice?
Well, what I'd say is that I think that everybody who was in a position of responsibility in the health family was acting according to what they thought was their best interpretation of their role in helping the country to manage an unprecedented situation. And I just think that especially in a pandemic, when everybody is involved in trying to get through this, every single member of the public, everybody is involved. I see the best in people, and I think that the best thing is to try to motivate people to do their best in this common mission.
What they were saying was that they'd exaggerated and cooperated with trying to create a climate of fear beyond the evidence. And I was just asking you whether you accepted that and you regretted the overemphasis on the negative.
But I don't think there was an overemphasis on the negative. There were thousands of people dying, and we needed to stop that.
Right. Can I just ask a couple of simple questions? One, you mentioned Portugal and moving it into the amber list, but there were other parts of the globe where there's virtually no infection. The best example I can think of off the top of my head is the Cayman Islands. Why weren't, as you were moving parts of the globe from green to amber, why didn't you move some from amber to green?
Well, the evidence is presented by the UK Health Security Agency, and the ministers then take decisions on the basis of that evidence. That's how we make the decisions to what's on the red, amber and green list. Sometimes there are balanced decisions when you could make the decision either way. In this case, the decision was it was very clear cut that we had to move Portugal off the green list, unfortunately. It gave me no pleasure to make that recommendation. And that's what we did. There are other balanced decisions that we will keep looking at the data and make an assessment each time we do.
Can I ask a couple of questions about Greater Manchester and Bolton?
Sure.
Bolton has had both surge testing and an increased supply of vaccine, which is going to everybody, essentially. Everybody
who's eligible.
Over Greater Manchester, there has also been an increase in infections, and Andy Burnham, the Mayor of Greater Manchester, has been asking that what has been given to Bolton is given to the whole of Greater Manchester. The surge testing, the support of the army is there, but not the vaccinations for everybody. Why is that?
Well, we have to make sure that we use the vaccines that we've got as appropriately as we can. I've been talking to the Mayor of Greater Manchester throughout this, and I'm glad that he welcomes the action that we've taken. It's clear that the package in Bolton has had a positive effect.
Absolutely.
And the challenge is that once you get to a much wider geography, including Greater Manchester and Lancashire, the more vaccination you put in, you've got to find those vaccines from somewhere. So we are working on what more we can do to get more vaccines into Greater Manchester, into Lancashire, to try to get the vaccination numbers up as well. But the immediate priority is to get as much testing done as possible so we can break the chains of transmission. Because you've got to remember that the vaccine takes several weeks to work, and not least because if you haven't had a vaccine at all, you need the second jab.
So that sort of wonderful Radio 4 programme, more or less. I don't know if you ever listened to it.
I think it's a fine programme.
It is.
Now, what did they say?
They tried to understand why Wales is the country, not just in the United Kingdom, but it's comparable to any country in the world in terms of the number of vaccinations it's got out as a percentage. And the conclusion they came to was that they had stopped holding stock, and as soon as they got the vaccinations, they got them into people's arms. And England and Scotland and Northern Ireland don't seem to have been doing that. Is that not a solution to the Greater Manchester and anywhere else that's suffering increased infections. The country stops holding on. There may be problems in the future in the supply line, but getting those vaccinations into people's arms is a good thing, as quickly as possible.
I'm grinning because I'm working out whether to give you the full answer, because I very much like my colleagues in Wales, and although we're in a different, with different parties running the devolved administrations, running the UK government, there is a very clear answer to why this happened. And because you asked so nicely, I'm going to set it out, and then I will phone up my new Welsh opposite number afterwards. The reason is this, that we need to ensure that whatever happens in terms of security of supply, there is enough vaccine for people to get their second doses. So we ensure that there is enough of a buffer that we can be confident that people will get their second doses. Now, it's a judgment how big that buffer needs to be. Our colleagues in Wales, as you say, decided to hold no such buffer and go ahead on the presumption that supply would come through. But they also knew that if there was an interruption to supply, that England's buffer would be used to ensure nobody in Wales would miss their second vaccination. Now, that is not a decision I could make for England, because I can't draw on anybody else's buffer. So I suppose what this demonstrates is that the value of the UK-wide vaccination programme and the fact that we've taken a whole of UK approach benefits everybody, including in Wales. It enormously benefits everybody living in Scotland, because we were able to procure on behalf of the whole United Kingdom. And I would argue that the vaccination programme demonstrates that the union saves lives. And in the case of Wales, the union has helped them to have one of the fastest vaccination programmes in the world. And I wish them every luck in the delivery of it.
Right, well, I hope you get on well with the Welsh. Go on. My final question, if I may, you mentioned at the start of the epidemic, you had difficulty getting information out of hospitals, in particular to find out what was going on. It's been my experience as a Member of Parliament trying to get information out of NHS England that they have had a very tight control both on press releases and on the supply of information. They've played the information close to their chest. I have found that difficult. So I wondered if that was your experience in the elevated position of being Secretary of State. Well, have you always been satisfied they've provided the information?
You should ask the chair his experience. The answer I give is that they are the supply of data, the use of data across the health family as a whole is infinitely better now than it was 2 years ago. And we have, through this pandemic, built a system of the provision of data for decision making across the NHS and PHE and the Joint Biosecurity Centre and the new UK Health Security Agency, in order to be able to make better decisions founded on the best possible data science. I think that has been one of the benefits of the work that we've done during the pandemic. And so it is much, much easier now. And I pay tribute to the team in NHS England and across the department and the other parts of the health family for those who've pulled that together.
Thank you.
As you can see, I'm a positive team player, and what I can say is this is one that's going very much in the right direction.
Thank you.
Thank you. Dr. Luke Evans.
Secretary of State, my questions are around risk. What's your attitude towards risk?
Well, sometimes you have to take it, but if you take it, you should then try to manage it. To give you an example, we didn't know at the start of this pandemic if we'd ever get a vaccine for sure, but I believed that we would and could, and was willing to throw everything at it. And then we took risks, for instance, backing 6 different projects even though only some of them have come off so far. And that was but then once we took the risk on those projects, we didn't just fire and forget and leave it. We then actively manage them. So you should take risks. It's one of the lessons of the pandemic that you need to take risks that are worth it, but they should be. I'm an optimist when it comes to making decisions like this, but I'm a rational optimist, and that means you manage risks as well as taking them.
You demonstrated that with, you said you put yourself on the line and put yourself in jeopardy with your 100,000 tests.
Yes.
But then at the same time, quarantine and vaccines, you've decided to keep some back as a buffer, and that's a conservative approach. How does that pan out when we come to having the debate about the lockdowns?
Okay.
Because from your position, and you're sat in the cabinet, you've set it well, you realised, I'm going to have to set this out to the Prime Minister that we need to shut the economy. I'm interested to know what the flip side was.
Yes.
Because throughout this pandemic, every measure is about risk management.
Yes.
No vaccine is 100%, no test is 100%,
Yes.
no mask is 100%.
Yes.
It's how you stratify that risk.
That's right.
Could you talk me through the first lockdown, how that worked?
Yes. So epidemiology is a science of risks, and it is all about the balance of different risks, where the typical projection of any particular figure is exponential in one direction or the other, and that leads to a particularly complicated set of metrics to understand in order best to manage. Now, fortunately, I'm trained as an economist, so whilst I don't have a clinical background, an economics and econometrics training, at least to the degree that I have it, it allows you similar training in the understanding of these concepts.
There's a really good point to that piece up, because for every measure that we put in at the very start, we locked down the entire economy and switched off only urgent care, and so all elective stuff was cancelled.
Yeah.
Rightfully so, for the capacity, what we've seen in Lombardy, you've set that out.
Yeah.
How did that change on the second lockdown?
Yeah.
Because you learnt the measures, you kept elective going,
Yeah.
and there was a reduced impact on the economy. How are those decisions made at the top?
So two answers to that. The first is, the answer I just gave also comes back to the discussion we had about testing, because we had an exponential demand for testing, but only an essentially linear, we got a bit above linear expansion of supply. And that's why we ended up having a shortage of testing at the point when the exponential curve got above what was essentially a straight line. And that's how it can be true that we continued to expand testing capacity and yet had shortages, because it's about the shape of the accelerating demand. When it came to the second lockdown, there's a similar way of conceptualizing this, which is that when case numbers are low but rising, you can see what is likely to happen but not certain. But you know when you bring in a lockdown that you have definite and immediate costs. And that makes for a difficult judgment, always based, of course, on imperfect information. So if I take an example for this, I know we're going to come on to the second lockdown later, but a really good example of this is the Kent variant, right? I remember having the meetings in November when we were under lockdown saying something odd is going on in Kent. And I remember being on a gold meeting and Helen Whately is a Kent MP, and she was saying there is something happening in Kent and it's different. And we didn't have at that time an explanation. And in fact, I remember having a conversation with a member for Tunbridge Wells about there is something happening in Kent, but we don't yet know. And we then found out it was because there was a new variant that was more transmissible. Now, the challenge when it came to the action that we took in December was that we didn't know exactly what the problem was. We were acting with imperfect information, but we knew, even though, for instance, in Tunbridge Wells, even though the case rate was very low, we knew that if we locked down, that would have immediate negative costs. So you have an absolute and certain cost versus an uncertain but projected much worse alternatives. And that the balance of those is an incredibly difficult judgment to strike. And the conclusion I've come to, having been around this loop many times now, is that you have to act early and you have to act firmly. And there is and that's when you don't have the tool of a vaccine. Now we have a different calculus, which is that we have to offset that, what I think of as the 2020 dilemma. We now have a vaccine, and we know that we're in a race between the virus and the vaccine.
So that's where I wanted to pick up. You preempted where I was going with this, because we've seen it 3 times, we've moved on. And of course, there's an important day coming on the 21st, and this is about lessons learned. The lessons learned about the decision-making, the economy versus the COVID health versus non-COVID health, and what happens to our freedoms on the 21st.
Yes.
How is that decision being come about? What's being put in to drive it? And what are the lessons that you've learned that you can take forward that we can put in our report for the next time, should this ever happen in another 100 years?
So the number, sadly, I expect us to have a pathogen similar to this to deal with in less than 100 years, and we need to be better prepared. One of the things that can make the world better prepared is better data. So, the data, and I've complained many times in this session, explained many times that everything was based on imperfect information, and that makes decisions much more difficult. But we have far better data now than we did, and we go through it each day and look at the trends. What we're looking at right now, the most important fact, is the link from cases to hospitalizations. And that link, the likelihood of a case turning into a hospitalization, not the absolute of any individual, but the population-wide risk, that link is falling. And the question is how far it's falling and how fast. Hence, we're watching the hospitalization data like a hawk. Now, it is hard to work out that function because there's a lag in there. As a former economic modeler, I'm skeptical of these models, but in looking through the model, it helps you to understand the data that you have. I think the decisions are best taken on the actual data that's in front of you, not necessarily the model, but a model can be useful to help you think about the likely future paths of the pandemic.
My final question to you, and I put it to you in the House a couple of weeks ago, about how rapidly this progressed. You were going to the G7 to discuss with the health ministers about a health surveillance and future plan.
Yes.
We do 50% of all genomic testing in the world on viruses. Is there a place for the UK to be leading that as a forefront, as a preservation plan for the future, so we have better data and surveillance to try and stave this off before it ever happens again?
There's no doubt that the UK has an important leading role in ensuring that we have better vigilance in the future. This vigilance needs to be not just on human health, but on animal health and the zoonotic links between the two, and on environmental causes of pandemics, or the conditions that lead to pandemics. I think that the G7 is an incredibly important moment for our like-minded allies to come together on this view. That's what we were talking about in Oxford last week, and the Leaders Summit will address this as well. But it is also critical that this is global, and so World Health Organization reform is vital to make sure that we get the transparency that we needed at the start of this pandemic on things like asymptomatic transmission.
Thank you. Secretary of State, we've been going for 3 hours, and I know that you're hoping it won't be another 7-hour session. So I wonder if I could possibly ask you, because we've got some colleagues who want to come in, just to be fairly brief in your answers. That would be great. Sarah Owen.
Thank you, Chair. Secretary of State, I've got some questions, about 5 questions on PPE, and I hope to get through all of them.
Sure.
So, and as you've heard, time is of the essence. But I want to take you back about 3 hours when you said, and you told the committee, there was never a national shortage of PPE because of the action we took.
Yes.
How can you say that when we saw with our own eyes nurses in bin bags instead of proper PPE?
Well, I can make that assessment because the National Audit Office came and looked at all of the details here. And look, PPE was a huge challenge. We had a stockpile and we released the stockpile in January. We started buying in February. From the middle of February, the British embassy in Beijing stood up a team to buy PPE, but it was difficult because global demand shot up, and we all saw that. But when the National Audit Office looked at this in the autumn, they found, and I quote, "The NHS provider organisations we spoke to told us that while they were concerned about the low stocks of PPE, they were always able to get what they needed in time." Now, I have acknowledged throughout that there were individual challenges in getting a hold of PPE, but at a national level, there was never a point at which we ran out.
Okay, that leads me on to my second question. Over 850 healthcare workers have died during this pandemic in the UK at a rate of 79 per 100,000 compared to a national average of 35.9 per 100,000. Around double the death rate for healthcare workers compared to the general population. If they were, as you say, properly protected and had proper PPE, can you explain that huge discrepancy?
Well, yes, sadly, there's so many health and social care workers have died in this pandemic. And that's because they're often at the front line. And of course, the PPE was important, but I have enormous admiration for and pride in those in the team who put themselves in danger on COVID wards when they knew that the people that they were looking after had COVID, and no PPE is perfect, and they and many sadly lost their lives.
Yes, and no PPE is perfect, but a bin bag is certainly less perfect than PPE. I'm going to move on to the kind of procurement process around PPE because you've touched on that. On the 31st of March last year at the Health and Social Care Select Committee, I asked how PPE was being prioritised and where social care was in that list. I didn't get an answer. Was it Michael Gove, yourself, Rishi Sunak, or the Prime Minister that was responsible for prioritising the PPE and what went where? Because Mr. Cummings came here and painted a picture of absolute chaos.
Well, I'm not sure how involved. Well, it was a government decision. You can, no doubt, in the inquiry, we can look into exactly who was involved in the decision making. But I take responsibility for the provision of PPE to the health and social care family. And what I can tell you is that at the start of the pandemic, the NHS supply chain provided PPE to around 250 NHS organisations. And because of this enormous global demand, which meant that the normal supply routes of PPE to primary care, to social care, and to community care, which normally is not provided through the central NHS supply chain, because that system effectively couldn't get hold of enough PPE, and it took the strength of government with our Beijing embassy, for instance, to be able to buy it. We expanded the supply route from 250 organisations to around 65,000 organisations, including, for instance, GP surgeries and care homes. And that was because the existing logistical system simply couldn't expand fast enough. And so it was a huge pressure, it was a huge challenge, and the team rose to that challenge to ensure that we did the best we possibly could. But as you've said, and I know, it wasn't perfect, but what you need to do in a pandemic when there's difficult problems like this is you work at it as hard as you could. And we brought in Lord Dighton, who provided a fantastic public service by leading this area of work.
Thank you. I don't think you've really answered the question with the greatest respect. You know, you can write and submit the evidence to the committee afterwards. It would be really good to know what the chain of command was when it came to purchasing PPE and distribution, because that is a key failing. And I think that the families of the 850 healthcare workers deserve to know why it was that their family members went to work unprotected, or as not as protected as they could have been?
Well, I think that this is a very important subject, and so it is very important to get this absolutely right. With respect to the provision of PPE to the health and social care sector, that is my responsibility as Secretary of State. But the other thing I'd say is that we've looked into this, and there's no evidence that I have seen that a shortage of PPE provision led to anybody dying of COVID. Now, that is from the evidence that I have seen. And what I do know, though, is that PPE provision was tight, and it was difficult throughout the world. But we did manage, it was pretty close sometimes, but we did manage to ensure that there was at a national level, we had the PPE, and then distribution was a challenge to all areas.
Thank you, Secretary of State. That's quite a bold claim. It would be really good if you could share that evidence.
Well, that is the information that I have, yes.
Thank you. You talked a lot about a team effort.
Yes.
And procurement is usually the domain of the Cabinet Office. Where was Michael Gove during the procurement process for PPE and COVID contracts?
Well, procurement is not just the domain of the Cabinet Office. The NHS procures at all levels. The NHS procures at a national level. Obviously, NHS organisations, whether trusts or GP surgeries, they procure. The department procures something, so it is a huge it's a huge effort. And the best analysis of this, I suppose, is the NAO reports, which they've because they've looked into this process right across the board.
How did you work with, because Mr. Cummings explained chaos and I think a clash of egos behind the scenes at Number 10 between different departments. How did your department work with the Cabinet Office, say, and the Treasury?
Great. I mean, I have an exemplary relationship with Michael, who's been a stalwart of the efforts and incredibly helpful. And when it comes to Treasury, the amount of money that the Treasury have put into this problem is unprecedented. And when I had problems, I raised it with ministers, and they were normally resolved. And if they weren't, that was because there was a perfectly decent reason. That's how government works.
That's a very different picture to the one that we heard. But do you think that Mr. Cummings' business relationship with Michael Gove was a reason for him being perhaps less critical? I mean, he barely mentioned him throughout the testimony, but gave you, I would say, a fairly rough ride during the 7 hours. Do you think it's fair to say that perhaps has clouded his judgment?
Well, I'm not responsible for anybody else's testimony, but I am really pleased to have the chance to come here to be able to tell you the truth.
And just lastly, on PPE, I've had a number, and we have seen a number of British PPE manufacturers and companies come out since this last year to say that they were either knocked back for contracts or were not taken up on offers to manufacture or procure PPE. And there were long-established British PPE suppliers. Why is it that they were overlooked for companies that had zero experience or had not even existed before the pandemic?
Well, when we came to buying PPE, we absolutely looked to buy it from anybody who could offer it and offer it for delivery. We looked into lots of options that were put forward to us by all sorts of people. The BMA, the Royal College of Nursing worked incredibly hard to find sources of PPE. The Labour Party made some proposals, and we looked into all of these, and the decisions on the individual contracts were made by officials, quite rightly. And my job was to make sure that we could fund it, that the funding rules, like the discussion earlier about the cap on the cost, those funding rules were appropriate for making sure we can get hold of PPE.
Final question, and it just relates to a question that my colleague Barbara Keeley raised, and I don't think we got to the nub of the answer. You've referred earlier in the session to saying that patients from hospitals were released to care homes because it took 4 days to test, and you just justified the discharge policy without testing on that. But on the 11th of March in 2020, the NHS website said that the majority of tests were being turned around in 24 hours. Now, which one is the truth? Is it Is it 4 days, or was it the NHS's website which says quite clearly the majority of tests being turned around were being turned around in 24 hours?
Yes, I answered this question around an hour ago.
Didn't
and,
answer it, which is why I'm asking again, sorry.
No, I answered this question around an hour ago, and I'll repeat my answer then, which is that if the tests can take up to 4 days to come through, not all of them came through within 24 hours, but even if, whatever the time period, the point is the same, is that you can catch COVID in a hospital after taking a test before getting the result. And critically, what I'd say is that that is only one part of the reason that the decisions were taken, and those decisions were all taken on clinical advice.
Dawn Butler.
Thank you very much, Chair. Thank you, Secretary of State. And if I can just pick up from where one friend just left off, you talked about procurement and the decisions being made by officials. Were you ever involved in any procurement contracts?
No.
Were you ever helpful to anyone pitching for a procurement contract?
Oh, when people came forward with potential leads, I would feed those into officials. Absolutely. And in fact, for instance, there was a moment, I can't remember the exact date, but there was a moment when Rachel Reeves wrote to, I think she wrote to Michael Gove, but it didn't, no matter, and with a list of potential leads, and we took those forward in the same way. This was a cross-party effort. Everybody was involved. So yes, part of my job was when I saw a lead, I would pass it forward.
Did you have any personal access with people, individuals?
I would pass them into the official system, and the official system would take them forward and they had a prioritization according to the likelihood of a lead.
I've got an email here from Samir Jasal, and he says in this email, Matt, you've been most helpful previously. What did Mr. Jasal mean by that?
I don't know. You haven't given me any context, so I can't really answer the question.
It's an email sent on the 6th of January 2021, and he talks about seeking validation. He talks about help basically with procurement contract. Do you know Mr. Jasal?
He has emailed me in the past, and I've replied, and I've made sure that his requests were dealt with in the appropriate way.
I mean, I think it's really important if we're going to learn the lessons to know, you know, if people who have special access, you know, he's calling you Matt, you know, if people have very special access to Secretary of State, how that works in the supply chain and how that works in terms of public procurement. I mean, there are several emails from, and it came from your department, from Samir Jasal and Surbjit Jasal, and I think Samir was acting as a middleman, and Surbjit Jasal's company went from £200 in value to almost £10 million in value in the year of the pandemic. Were you aware of that?
No, but when people brought forward proposals for PPE, to be able to supply PPE, I passed them on to the team who took them forward, and decisions on individual contracts were made by officials. And I think anybody...
So you'd always pass them on, you wouldn't have a private conversation or email exchange with, say, Mr. Jasal?
Well, it depended on the circumstances, but I would pass on an offer, and then the team would look into it. That's how this worked. And and if you think about it, obviously I would, because if I did the opposite and ignored likely offers of PPE, then I'd rightly be criticised.
I completely agree. I just wondered why you would have time to give special attention to an individual person. Can I just move on? How do you feel?
I don't know whether I have.
How do you feel about the government's counter-fraud function proclaiming that there was a high risk of fraud in procurement of PPE?
Well, we were buying PPE as a government in order to protect lives, and we were doing it at a time of extraordinary global demand. And I just want to put on the record, if I may, Chair, my thanks and admiration to the team who made sure we never had a national shortage of PPE, because they come under, I'll finish, thank you. They come under pressure, and in my view, some unreasonable... This is the
lessons learned.
Yes, that's right.
Lesson committee. I mean,
right.
you can do all your thanks at the end, Secretary of State. I mean, I too...
The lesson I learned,
Secretary of State,
the lesson I learned is that
everyone's got a limited time, so if we could possibly let Dawn Butler continue her questions.
Dr. Evans mentioned earlier about your attitude to risk. Do you know what the risks were in regards to procurement of PPE?
Yes, I knew the risk was if we didn't buy enough, people wouldn't have enough PPE. And thankfully, because my team did such an excellent job, we never had a national shortage of PPE.
Your department's one of the few departments that hasn't estimated the risk of fraud and what that looks like in its department. Why is that?
We have a very significant counter-fraud agency in the NHS that does a huge amount of work to make sure that we tackle fraud and the problems that come from it.
Why haven't your department given the evidence to what that fraud might look like in the Department of Health? Other departments have said, this is what fraud might look like in our department. This is, our attitude to risk. Your department hasn't done that. Why?
I'm not aware that that's right. I'm very happy to write to you with details of that.
Okay, so we need details of what the risk looks like in the Department of Health and what fraud would look like in the Department of Health.
Yes, and I'll set that out in the context of the fact that there was a global scramble for PPE and the department desperately needed to get hold of the PPE and succeeded in doing so.
I understand that, but it is public money, and so we do have to account for risk of fraud in that regard. There's lots of paper trail to this. Most people can find it. You are aware of the Good Law Project, obviously. The government's just lost a case this week. This case cost £600,000 to defend. And so the government spent £600,000 defending an unlawful conduct of the contract more than what the contract was worth. Do you think that's value for money?
Well, that wasn't in my department, so it wasn't a judgment that I made or know any of the details of. What I would say is that the judgments that we made at the time were based on what we needed to do to deliver at pace in very difficult circumstances. And the team really drove that through because they had to.
Thank you. Actually, a lot of the emails are on the Good Law Project's website and Twitter address. Just so I put it on record so your department can look it up. Can I quickly just touch on you spoke earlier about people being very enthusiastic to give their data. I think you're over-exaggerating how enthusiastic people are about just giving carte blanche access to their data. Are you aware that Palantir and faculty have links to the discredited Cambridge Analytica?
I'm not. I don't think I'm aware of that. No.
Okay. I think it's really vital that you should be aware of that. It's Palantir reportedly taught Cambridge Analytica how to scrape data. That means that you're putting at risk everybody's data in the country and giving it to organisations such as Palantir.
No,
I think it's really important that you get to grips with that. And I will give you this little book of data and democracy and some information for you to help inform you, Secretary of State. Just a couple of quick yes or no responses. Do you have any other agreements with companies that will help supply data that will help analyse voting intentions?
I have no idea what you're asking about.
I'm asking about, in our previous session, when you came in front of the committee, I asked you about unsolicited questionnaires that were being sent to people, asking them how they intended to vote in the next election. You said you didn't know anything about that. Now we know more about Palantir's and faculty's involvement in the NHS. It seems like this is all could be used as part of a way to get data about how people are going to vote and to encourage people to vote a certain way.
Lessons learned inquiry that we're doing, because we do need to make sure the questions are on that topic.
Yeah, it is, Chair, because I think the lessons that we must take from this pandemic is that in a pandemic, we cannot use this as a shield to be able to get people's data, to be able to use with it whatever a government wants to use it for.
Okay. Do you want to then ask your final questions then?
Secretary of State, are you 100% sure that Palantir, faculty, Cambridge Analytica, or any other offshoot companies are not supplying public data, voting intentions, anything like that to the Conservative Party?
Well, what I'd say is that this has absolutely nothing to do with it. And where your accusations are unfounded and wrong is when you said that the companies involved in improving the way that we use data in government and have made huge positive strides in doing this in the last year and a half, that those companies, the words you used were have carte blanche. And that is not true, because all of this work is done within strict, careful protocols to make sure that we can use data to save lives. That's what I was doing. And I know that there are various theories in this space, but you've asked me the question and I'll answer it.
This is not a theory, Secretary of State.
There are various theories in this. What matters is, can you use data better to save lives, ensuring that it is properly and appropriately protected? And that's what we do.
Secretary of State, 100%.
Question, if we may.
Secretary, 100% you can use data to save lives. Of course you can. You can also use data to manipulate people and manipulate lives. And that is not where we want to go as a country or as a government. So this isn't about theories. These are about factuals. These are about how you use data. My last question, Secretary of State, have you visited the COVID Memorial Wall?
Not yet, but I very much hope to.
Thank you.
Thank you. Dean Russell.
Thank you, Chair, and thank you, Secretary of State, for attending today. My question builds on data and the importance and the role of technology over the course of the pandemic. It seems to me that we quite rightly are talking about positive aspects of the vaccines and the testing, but actually data seems to have been at the very heart of much of the work we've done. And I wondered if you could explain what lessons we've learned over the course of the past year or so in terms of the growth of how we've used data and how we've collected data to save people's lives.
Well, we have used data, I think, better in the health and care system over the last year than ever before. And we've proven the point that you need high quality, rigorous use of data and data architecture that protects privacy, to make sure that people can be reassured that some of the conspiracy theories are just that, whilst making sure that you can improve care. And really, the proof point of this argument is the success of the vaccination program, both its operational success, because we drew up a very high quality data architecture right at the start, learning the lessons that we'd learned during the crisis, but also in terms of how that's then applied on the ground. We use data to be able to target groups who need an offer of a vaccine brought closer to home, for instance, to make sure that they get the opportunity to have a vaccine and the opportunity to consent to do that. So that's just one example of how this has improved, but there's so far to go for the NHS to really get the value out of the data that it holds.
And can I ask, actually, outside of the pandemic, obviously moving forward, we've got a real rich sense of data, and I think that the country's got used to dashboards now in a way that perhaps a year and a half they wouldn't have even considered.
Yeah.
From the daily briefings and from what the public can interrogate.
Yeah.
How do you see that playing out moving forward outside of the pandemic? Do you think that sort of information will continue to be available?
Well, I think there's huge strides forward that we've made that we've got to keep pushing on. So, for instance, using data for research purposes so that we can get new treatments and find them and get them fast to people. Using data to make sure that we can better manage things and have better coordinated delivery of care, for instance. Using data so we can take preventative action to stop people getting ill in the first place. I mean, we're going to launch a data strategy for the department that will set all this out in detail. But we've made in the next few weeks. We've made big strides, but there's a lot further to go.
And so, would you say then, moving forward, and especially a lesson from the pandemic, that actually data is going to be at the heart of the NHS moving forward? Would that be? I very much hope so. The opportunities here are huge. Yeah. There are opportunities to save lives, opportunities to improve care, opportunities for the UK to be at the forefront of, of research. Just one small example before we move on. The recovery trial, based out of Oxford University, led to the discovery that dexamethasone
could save lives from COVID. Over 1 million people are alive today who would have died. That's the latest estimate because of that discovery based on high quality NHS data in the recovery clinical trial. I think that is a really good example of the sort of thing we can do if we get this right.
And from a personal perspective, in terms of one's own health data, so many people now wear Apple Watches, they track everything with their apps and their phones and so on. It seems to me that in the 20th and 19th century, people donated organs. There's an opportunity moving forward to save other people's lives. There's an opportunity to save more lives by donating data effectively, anonymously and securely.
Yes.
Do you see that as being part of that ability to save, potentially find cures for cancer?
Yes, of course. I think that my view is that every citizen should allow their data to be used, as you say, anonymously and carefully for research purposes. I think, and we've seen that happen during COVID, and huge numbers of people came forward and signed up for that approach. And I think it's something we can learn. In fact, what I'd say is that the public as a whole, the UK, everybody across the UK, has got far more used to dealing with data and their health data in particular. The final thing I'll say on this, because I know you want to move on, Chair, is that the data on your personal health, your health record, in my view, that belongs emphatically to you. It doesn't belong to your GP. It doesn't belong to the NHS. That is your data, so that people should be able to care for you based on that data. And if you want it to be used for research purposes, that's your decision.
May I ask one very small question, if I may? It just relates to when we look at organisations like Apple that are excellent at collecting data and have the tools and facilities to do that. Do you see an opportunity to sort of partner more with those sorts of big organisations who are already tracking people's heartbeats and say, look, could we find a way to help that improve people's health as well?
Well, up to a point, but what really matters here is that we can maintain people's trust and consent in the process. Personally, I'd be very happy to do that. But we need to bring people with us on this one.
Thank you.
Thank you. I think you may find that predecessor health secretary have the same view about who owns your personal data. Aaron Bell.
Thank you, Chair. Thank you, Secretary of State. I've got the topic of vaccines, and I will try and be as quick as I can, but I fear we may not. We may not get it all done today. So, on behalf of the Chair of the Science and Tech Committee, perhaps you might come and speak to us at further length about vaccines in the future. I mean, obviously, they've been the triumph of the whole thing. It's, the development, the procurement, the deployment has been world class. Doesn't mean there aren't lessons we can learn. It's also been a personal triumph for you. I wanted to ask you about a quote from last October, October 17th, by Katie Balls. Matt Hancock is the only person here who thinks there's actually going to be a vaccine, said a Whitehall source. Quotes, it's a running joke with other departments. Is that an accurate reflection of your position in government with the vaccine, and who do you think that quote may have come from?
Well, I have no idea who said that, and others may speculate. And it was a view that was held amongst some, but the whole health family was absolutely determined to get a vaccine over the line. We first talked about it in January, and the advice was it would take, I said at the start, it'd take a year to 18 months if everything went well. And I set the team the target of getting on within a year, and we delivered on that. And I'm incredibly proud of the team who pulled it off.
Thank you. Dominic Cummings told us that the vaccines were actually taken out of your department to ensure that it was done successfully with the vaccine task force. Do you think that was the right move?
Well, there was a big team effort on the vaccines, and Alok Sharma played a vital role in this because the industrial side and the science budget are in Bayes. The deployment, of course, is on my side of the fence. Ahead of the deployment, we just worked together as a team. There were some people who weren't very involved in vaccines and never believed that they'd happen. And I would say that partly because we just got on with it and we didn't have interference. That's one of the reasons why the vaccine project was so successful. We brought in Kate Bingham, who did an amazing job. One of the reasons Kate did such a good job is because she brought with her a huge amount of talent as well and had the same team attitude. There were some times when I had to make big calls and was happy to do that, but most of the time I let the team get on with it.
On that one, Did you, as was reported, overrule your officials on the Oxford AstraZeneca order and increase it from 30 million to 100 million? Was that a personal interference that you made?
Well, yes, but it's unfair to say that that was overruling. The advice was to buy 30 million doses. I said that we needed to make sure we had enough for the whole adult population, even if other vaccines came off. And so I decided that we needed 100 million and then got agreement with that across Whitehall. There were other areas, for instance, Oxford University, who of course have done this brilliantly, were initially lined up with a different vaccine company, but I was determined that we would have UK manufacture with a UK provider, and critically make sure that we had an exclusive contract to those critical early doses. And when the other manufacturer was not willing to sign up to those conditions, we switched to AstraZeneca, and Oxford signed the deal with AstraZeneca with government support, and the rest is history. So, you know, I had my red lines on this, and I provided the resources and the leadership, tried to make it happen. But it was, this is not my personal success. It is a massive, massive team effort.
So you said earlier, probably about 3 hours ago now, that you were advised that it would take 5 years on the 25th of January.
But it would normally take
5 years. At that point, actually, Moderna had already designed their vaccine. The genome of the COVID-19 was identified on the 11th of January. They had their vaccine designed on the 13th. I think it was the first trial dose anywhere was on March the 16th. Could we have done things even quicker? And I accept it's been breakneck, but could we have done things even quicker? What lessons do you learn from that? What lessons should the scientific community learn from that? And should we have adopted human challenge trials, given the scale of the pandemic and the devastation it's, economic and health?
Well, I think it's worth asking an expert like Jonathan Van Tam or Clive Dix if you want a view on whether we could have accelerated human challenge trials. My view was I pushed for the system to go as fast as possible, for them to use human challenge trials. But I was not prepared to go faster than the science would credibly allow. And when it came to other clinical trials, I do hope that for variant vaccines, we'll be able to get them through quicker because the platform will have already been approved. And the agreement that we made in Oxford last week at a G7 level will undoubtedly speed up future vaccine production. And the reason for that is that at the moment, in each country, clinical trials are essentially separate, because the design of the data standards can be different in different countries, and therefore you can't always amalgamate the data and therefore get the extra power that you need to get a clinically validated result as soon as you could if the data standards were the same and therefore the data is interoperable. This may sound technical, but the consequence of that clinical trials charter that we aim to implement rapidly will be that we'll be able to get both vaccines and treatments faster and with a more diverse range of clinical trial treatments. It's that sort of, granular hard work improvement that we need to be doing to make sure we're better prepared in future and can do these things faster still in future.
Yeah, absolutely. I mean, I completely understand you obviously didn't want to compromise on safety and the regulatory approaches, but do you think that there was perhaps an element of groupthink in the scientific community that didn't recognise that the scale of what the world was facing required a change to scientific methods to try and produce these things even quicker than we did?
No. What I'd say is that the MHRA under Dr. June Rain did an extraordinary job of removing anything that was on the critical path whilst maintaining safety standards. Probably the most important innovation, you'll have to ask her, but I think the most important innovation that they came up with was the idea of a rolling data, which meant that they, instead of doing the trial, having the data package, submitting that to the MHRA, and then the MHRA analysing it, the main vaccine companies opened their data to the MHRA during the process, so the MHRA knew where they were up to. They still needed to then check the final results, but that took a matter of days, not weeks. There's one other thing we've learned. which is that the NHS itself has such good data systems now that after deployment, you can track the effectiveness of a particular treatment, whether it's a vaccine or a medicine. And therefore, effectively, deployment in the NHS is itself a very large clinical trial. And that raises a longer term question of whether the Helsinki Declaration that currently is the guiding international treaty on, no, it's not a treaty, the guiding international principle on clinical trials could be improved to take into account the fact that now in later stage, you're actually watching what happens. But that has to be done carefully, it has to be done rigorously, it has to be done with scientific backing of the experts. You can't just wave a magic wand and say, this could have gone a whole lot faster, because you have to make sure you have the clinical confidence in safety and efficacy, otherwise things wouldn't work. And the proof point of that is that we managed to get the vaccine at record times, but we still have uptake in 96, 97%. We have the highest enthusiasm for vaccines in the world because we took the approach that we did. And we didn't either just remove steps that were required for safety, and we didn't stop clinical trials early as they did in some other countries on hydroxychloroquine. You might remember some quite influential figures decided early that it was obviously right and declared victory on it. But when the recovery trial saw it through to the end, when you got a clinically validated, statistically accurate answer, it found no benefit of hydroxychloroquine. You have to follow the science on this. And this is one of the areas where Britain absolutely nailed it. And political intervention to undermine that science would have been wrong. So I was willing to drive and intervene where it was appropriate, but I absolutely would not undermine the science in this area. And that's one of the reasons that it worked so well.
Okay, if I can just finish. This is lessons learned, obviously, for the UK, but I think there are lessons for the global scientific community. We've already talked earlier about some of the things that SAGE got wrong, that we got wrong internationally, that the WHO got wrong, that you were referring to the asymptomatic transmission. Do you think they got it wrong on the origins of the coronavirus? We've now seen this lab leak hypothesis is gaining a lot of credibility around the world with intelligence agencies and scientists. Do you think that the WHO let us down on that at the start of the pandemic?
Well, I don't know, and nobody knows. I know the clinical advice, and that is public. But I think it is vital that we have a fully independent investigation in China into finding out all we can about this, and that is allowed to happen unencumbered. And part of the reforms that we need to the way that the worldwide systems operate is to make sure that we can properly find answers to these questions, because at the moment it is impossible to know.
It will be hard to get into China. It will be hard to get into China, but do you feel let down by the way the British scientific establishment backed up the original position of the WHO without any real evidence for doing that?
No, I don't. No, I don't. I think that we do need to get to the bottom of this. But of course, for the day-to-day management of a pandemic, the origin is only a secondary consequence. What matters is the problem that you've got in front of you. Now, for learning the lessons and avoiding future pandemics, these things are very important.
Thank you.
Thank you. Karen Monaghan.
Thank you, Chair. Secretary of State, thanks very much for spending so much time with the committee today. I think all of us appreciate that. We know that in March, things were obviously frantic, and you've said this morning that you had limited info and you're working at great pace. By September, we should have had a clearer idea of what we were dealing with. So I'd like to just ask some questions about that. In September, the Prime Minister rejected SAGE's advice for a short circuit breaker lockdown. Dominic Cummings told us 2 weeks ago that the Prime Minister took that decision without consulting Cabinet and without any formal advice against a lockdown. What's your recollection of the decision process?
Well, the challenge of having a 2-week so-called circuit breaker is the question of what you do at the end of the 2 weeks. So in Wales, they did try a 2-week lockdown, and at the end of the 2 weeks, the cases started to go up again. The scientific theoretical argument for a 2-week circuit break is that if everybody on the planet didn't see a single other person on the planet for 2 weeks, then the disease would not be able to pass on. But unfortunately, in real life, that obviously can't happen. So the practical question in this period was what action to take to slow the spread of the pandemic. And we turned to the tiers system and then to a national lockdown in November. And of course, during this whole time, we had the growing problem that we only fully knew about in early December of the new variant that made life so much more difficult.
Did the Prime Minister discuss this circuit breaker that Sage was advising with the Cabinet?
Well, I certainly discussed it with him. I can't recall whether it was specifically discussed at Cabinet, but I know that I discussed it with him.
And did anyone challenge the Prime Minister's decision?
Well, we had an ongoing debate over that period as to what the appropriate action was, given that there were rising cases, especially in some parts of the country, but it was very regional, whereas the first peak had been uniformly national. And then we took the action that we did towards the end of October.
Okay, Mr. Cummings also claimed that in September the Prime Minister had said, we shouldn't have done the first lockdown and I'm not going to make the same mistake again. Is this true?
I've certainly never heard the Prime Minister say anything like that.
Okay, so, I mean, if this isn't true, why was there not more discussion about the circuit breaker lockdown?
I'm sorry, that's a non sequitur.
But why was there, when Sage was giving clear advice for a circuit breaker lockdown, why was the decision taken? You've said, what do we do after the circuit breaker? And we all understand what a circuit breaker is. But why was there not more discussion about a lockdown, the requirement for a lockdown in September?
There was a constant discussion about how to respond to the rising case numbers. You know, I said in public at the end of August that we could see a second wave coming. And from that time onwards, we had a debate in government about these incredibly difficult balances. And we took action in the local areas where it was needed.
You've previously told our committee the circuit breaker lockdown you felt was disproportionate. But it's also been reported that you yourself argued for that very circuit breaker. What is the truth of this? And if you're arguing for the circuit breaker lockdown, why did the Prime Minister reject your advice?
He didn't, and also that it misrepresents the way that governments make decisions of this magnitude. We have discussions of the pros and cons. Now, of course, as the Health Secretary, I am inclined to take the cautious view. That's my job. And my job was to protect lives and to get us out of this. That has been my central mission for the last 18 months since the 1st of January, when I first heard about this virus, and certainly since it became clear that it was coming here a month or so later. And so of course, I'm going to make the cautious arguments. Others make arguments for the absolutely serious, real and immediate costs of lockdown, as it was discussed. We did this on a regional basis over the autumn until November. We then had the national England-wide November lockdown, and then we had a regional approach over December until the January the 4th lockdown. And all that while, the situation got more difficult to manage because of the rising number of proportion of the Alpha variant, as colleagues from Kent, I'm sure, are delighted that it is now called.
Okay, one of the points that Mr. Cummings made repeatedly to our committee a fortnight ago was that decisions were taken by the Prime Minister himself, and he would ignore other people's opinions or advice on this. Is that the case? Is that your experience?
No, I discussed all these issues with the Prime Minister throughout. Yeah, I speak to the Prime Minister almost every day, usually several times a day, and have done since I first alerted him to this problem on the 7th of January. You know, it's an incredibly intense period for any government, and remains so, because these judgments and the consequences of the judgments that we make affect everybody in the country. So this is and the way that decisions are made is through discussion. Of course, people have a tendency, one side of the argument or the other at times. Actually, at the moment, everybody is very aligned, and the data is still not yet clear ahead of the 21st of June decision. But but the way that decisions are made is that they make their argument, and then the Prime Minister makes the decision, and then you fall in line behind that decision, because that's what collective agreement is all about. And ministers go out and explain it, and advisors advise.
So what we are trying to establish is whether the picture that was painted by Mr. Cummings is a true reflection of what was taking place, whether it was a one-person decision, whether Cabinet were involved, what advice was being taken on board. This is really what I'm trying to get to.
Yes, and what I'd say is that I spoke directly to the Prime Minister throughout this period, and he took advice from a huge range of people, as he should and as he does.
Okay, the point of learning lessons is to identify where things have gone wrong, identify mistakes, and address these for future. Hopefully we won't have another global pandemic, but even for future dealings with COVID. What would you do differently? And
where to start? There's so much that we've learned. Okay, the best place to start is probably the things we do differently now to at the start. Right? We have different policies on protecting care homes. We have different policies on the border. We've learned a huge amount all the way through. So a lessons learned exercise is not.
I'm sorry, when we see 3 weeks for the border from India to be closed,
you don't. Well, you don't. You see, no, you don't. We acted when we saw the data, and
the data showed from Public Health England shows that the Indian cases positivity from India was 3 times greater than the positivity from Bangladesh, but that data was not acted upon for 3 weeks.
But we didn't have that data because there is a long lag from the cases, the date on which the case occurs, to the date when the sequencing result comes back. So you have to act on the data that you have. I keep repeating this whenever I'm accused of by somebody with the benefit of hindsight that I should have acted sooner, and I'm trying to stress it during this whole.
I think many people were asking to act sooner in the early days of April, and that didn't happen.
But well, you know, the different governments across the United Kingdom, including the SNP government, acted at the same time in these things, because we're acting based on the same scientific advice.
No, that's not true. The SNP government closed the borders.
We're going to conclude.
You were referring to the period of March and April last year, and we all had the same.
No,
scientific advice.
I'm talking about April of this year.
Do you want to come back on that, or should we move on?
Well, the government in Scotland took a different approach, and international travel is essentially, the rules around international travel are essentially a decision for the UK government, but I'm not particularly.
I'm going to have to move on to the next question. And you've been very generous with your time. We've just got 2 more people. You can see them on the screen in front of you, and then we will be through. So, Paul Bristow.
Thank you, Chair. Secretary of State, just to probe slightly further on those decisions made in September, what Mr. Cummings told us very directly was that by September, it was the economic arguments against lockdown that outweighed everything else. Is that correct?
It isn't correct, because what you have to do when you're making a decision as a minister or as the Prime Minister is weigh all of the factors. You have to weigh the economic factors. They are real. People's livelihoods are at risk. But you also have to weigh the health factors and the growth of the virus. And so the proper and appropriate way of taking a decision is to listen to all of the voices, and some voices were arguing one way and some arguing the other, and then you have to take a decision based on those judgments.
So where did the balance in decision making lie between scientific, medical, economic and social factors, and how did they change over time?
Well, ultimately, that balance is a balance that only the Prime Minister can bring together. You know, of course, I will make the arguments that I believe in, and representing being the head of the health department and the health family, if you like, I'm going to make that argument. But ultimately, these judgments come together through the Prime Minister.
Okay, just on a slightly different question. On May the 27th, you said that the new variant, I think we're talking about the Delta variant, may represent as many as 3/4 of new cases. What's the most recent assessment of this?
The assessment that I saw from last night is that the Delta variant now comprises 91% of new cases in the UK.
91, okay, all right. Just to return to some of the questions that Barbara asked you, I just want to refer to this, just on a slight point on what we talked about earlier, 2 or 3 hours ago, on DNARs, on the resuscitation notices. You said that no one was denied treatment, and your guidance, actually, or NHS England's guidance on DNARs was very clear. But what the Daily Telegraph is saying today is at least one person died because she was issued with a notice which very clearly said learning disability was listed as the reason that CPR was likely to be unsuccessful. I know there's many things or many factors or many suggestions that you're looking for, levers really, to try and ensure that guidance is issued across the country and people act appropriately. But could you at least commit to investigating this one particular case?
Absolutely.
Very clearly.
And if you or the Daily Telegraph or anybody else has other cases of people disobeying the guidance, then I want to know about it. And the CQC is there to investigate formally as the health regulator to make sure that this sort of guidance is followed. When I said what I said, what I meant, of course, is that is what the guidance states. People should not do it. Now, in a system as big as the NHS, making sure that happens everywhere is a challenge, in the same way that on patient safety issues, for instance, everybody follows the guidance. Making sure everybody follows the guidance is a challenge. That is always a problem with a very large system. But as Secretary of State, along with the entire clinical and non-clinical leadership of the NHS, I am absolutely crystal clear that having learning disabilities is never a reason for a DNR notice, and consent properly attained must always be taken on an individual basis before a DNR process should ever be put in place.
Thank you very much.
Last but not least, Taiwo Owatemi.
Thank you, Chair, and thank you, Secretary of State. My first couple of questions will just be about lessons learnt in the past 18 months and what can be done, what could have been done differently. Firstly, do you accept that the large staffing shortages that the NHS already faced made it more difficult for hospitals to cope during each wave of the COVID-19 pandemic?
Well, I think the best way of putting it that I can think of is that I'm just delighted that we were recruiting at pace when we went into the pandemic. And then we recruited very significantly in the early days of the pandemic by having a call to arms to people, including people who'd retired, people who were in the latter stages of their studies, and others to come forward, whether as volunteers or to become fully fledged clinicians or into all sorts of other roles.
Sorry to interrupt you, but what I'm trying to get at is, how are we going to avoid such dangerous and widespread staffing pressures in the future?
Well, the starting point is that we're going to deliver on our manifesto commitment to have 50,000 more nurses in the NHS. I'm very glad to say we're on track to delivering that manifesto commitment. And I'm looking forward to working with the committee to think about how we can make sure that there is always an assessment of what's needed, not least with the passage of the Health and Care Bill in the forthcoming session.
Well, I hope the 50,000 nurses are actually 50,000 nurses who are registered in universities to actually practice nursing rather than something else. Secondly, just moving on to ICU beds, do you think that the comparatively small numbers of ICU beds across the NHS compared to our European neighbours put us at a disadvantage when coping with mass hospitalisation caused by COVID?
Well, thankfully, because of the actions that we took and because of an expansion of ICU capacity done in emergency circumstances, we were able always to give treatment, but there is no doubt that one of the lessons is that we needed more ICU capacity, and we have expanded it over the last 18 months.
And will that expansion stay in place in many of them?
Yes, I mean, earlier I mentioned the Nightingales project, and there's no doubt that the Nightingales project is something that the NHS should be always proud of. You know, do you remember we saw those images of China building a hospital in 2 weeks, and we thought, well, we'll never be able to do that here. And then we built one in 9 days. So the NHS should be very proud of what it did on the Nightingales project. But that, of course, was temporary. We also expanded permanent capacity, both in ICUs and in emergency departments, actually, because, you know, infection control rules mean that you can't have as many people in waiting rooms in emergency departments, and so they needed expansion as well. So almost every emergency department, almost every A&E in the country has been expanded in the last 12 months. So yes, some of the expansion is permanent, some of it was temporary.
Roughly how much ICU beds are you planning to keep permanently then?
That is a great question. I don't know the answer. Can I write to you?
Yes, that's fantastic. Thirdly, throughout the pandemic, do you think that critical NHS infrastructure, such as oxygen supplies in hospitals, was ever under sufficient pressures so that patients' lives weren't put at risk and NHS staff safety weren't put at risk?
Yes, there were moments when we had a significant shortage in an individual setting. So there were hospitals that got to the limit of the number of patients they could have on oxygen. That wasn't the actual oxygen itself, it was the piping, it was the supply mechanism. But because of the NHS, we were able then to divert patients to other hospitals and in some cases move them to other hospitals. I mean, it's one of the many advantages of having the NHS during a pandemic. And, you know, as I said at the start, you know, some of the things that went well were because we had such strong institutions. And in this case, we had the NHS, which had record funding and record levels of staff going into this. And thank goodness that we did, because it meant that we were able, with the expansions, to always provide care have that care available for COVID patients.
Just following up on that, will your department look very closely into the several near misses in hospitals across the country where critical infrastructure did very nearly collapse under the pressure of the pandemic? And how can we ensure that the critical infrastructure is not at risk of being overwhelmed in the future?
Yes, it's a really important question about the resilience of the NHS in the future. Firstly, system working in the NHS so that if a hospital is coming near to being overwhelmed, then it can move patients to a nearby hospital, or sometimes to quite a distant hospital. That is very important. But so too, here again, I come back to the data, is understanding which hospitals have spare capacity. We are so much better at that than we were 18 months ago. And so there is a big operational role for making sure that the NHS can deliver that care as well as possible.
Well, just for my last question, and this is a question that I'm sure that members of the public have all been asking, and a question that I actually want to know, and my constituents in Coventry North West want to know. Previously, you said that there is nothing in the data to suggest that we are definitely off track to remove restrictions on June the 21st. Is this still your view? And essentially, is June the 21st the end of restrictions?
Well, you tempt me, but unfortunately, I'm not going to be able to give any more information about this ahead of the Prime Minister setting out the decision on Monday. As you can imagine, we're looking at this data every single day, but I don't want to give an answer that would give a hint one way or the other, because I think we've still got a couple more days data to look at, and we'll make the decision very soon. But if I could just also add something to my previous answer, the thing is that having the NHS made the UK better placed in terms of the healthcare provided than many other countries. And I think one of the really important things for any lessons learned exercise is that we must learn about where we need to strengthen and improve. And even in the good areas, we can still strengthen and improve, but we must also recognise and acknowledge those areas like the NHS and like British science, where our strengths meant that we had an exemplary response.
Thank you.
Just moving on to the data. Just one question. Are you
Okay, final one, Taiwo, and then we need to move on.
Thank you, Chair. Just moving on to my previous question. Are you at least able to give us your own personal views on the data so far?
I'm afraid I'm not, no. I'm going to talk to the Prime Minister and others and listen to what the Chief Medical Officer has to say about it, and then the government will come to a conclusion.
Thank you, Taiwo. Secretary of State, you've been very generous with your time. There's one final issue. We've sort of elided the sessions in order to try and get you through this as quickly as possible. There is one final issue I know that NHS staff would want me to cover briefly before you go, and that is about nosocomial infections. The Guardian recently established from FOIs that 8,700 people had died after picking up COVID in hospitals. Now, some of those may have died with COVID rather than because of COVID, but do you accept that many people are likely to have died because they picked up the infection inside hospitals?
There's no doubt that there was nosocomial infection. The degree is hard to estimate because some people go into hospital and have caught COVID in the community and then only become either symptomatic or only have enough COVID to be tested positive for it once they reach hospital. And I hope that isn't too, that doesn't sound like I don't take it seriously. I take it very, very seriously, but the precise numbers are hard to ascertain.
One of the things that might have helped prevent that would have been earlier regular testing of NHS staff. Now, you explained earlier in a lot of detail the efforts to ramp up the testing.
Yes.
But you had to follow the order that you were given in terms of the clinical guidelines as to who to prioritise for that testing. And that meant that regular testing of NHS staff wasn't introduced across the system until November. Looking back and knowing what we know now, do you think that we should have found a way of doing that earlier?
Well, we only could have done that if we'd had the extra testing capacity, and that is the challenge. It was really the validation of lateral flow tests in the autumn that made the big difference there. And so the twice-week testing with lateral flow device is incredibly important and has helped undoubtedly in reducing nosocomial infection. So what I'd say is that for the lesson for the future for me is to make sure you have that testing capacity as a standing capacity ready to go.
Could another reason be that with an airborne virus, some hospital ventilation systems just weren't good enough?
Yes, that is definitely another lesson as well.
And final thing, do you think that some of the instructions that went out to hospitals about social distancing and other precautions in the non-COVID areas of hospitals took too long? So the 2-metre rule, for example, wasn't introduced until May. And do you think that's one of the lessons or one of the things we need to look at?
Well, I think it is worth looking at the entire infection prevention and control approach throughout, because I've no doubt that knowing what we know now, we can make an assessment of that. But of course, these judgments were the best judgments that people working their hardest based on the best information they had. And in a way, I return to what I've said so often, is that these were big calls made on imperfect information and often made at incredible speed against a novel pathogen. And so I don't want to imply any criticism of those who developed that IPC guidance. What I'd say is the lesson for the future is to be able to understand any pathogen as fast as possible so that you can produce the best possible guidance as quickly as possible.
Thank you. And final question to Greg Clark.
Thank you very much, Jeremy, and I join Jeremy in thanking you for your commitment to the committee in terms of the time that you've given this morning. Perhaps looking back, Given that we want to learn lessons that can be applied during the remainder of this pandemic as well as in the future, if we were to have, God forbid, a vaccine escape, that's to say a new variant that was resistant to the vaccines that we have, do you have a plan for that?
Yes. It is the life of a health secretary to worry about these things. The plan is predicated on having a variant vaccine as fast as possible. Now, the Prime Minister set a target of having a variant vaccine and treatment and diagnostics within 100 days, but we are not there yet at that speed of turnaround. However, the mRNA technologies, as the chair set out, can develop a vaccine for an individual new DNA or RNA sequence very quickly, within a matter of days. And now that the platform has been not only approved with full clinical trials, but applied hundreds of millions of times across the world with the tracking of the data in many of the countries, we can have confidence and so move to very late stage, move through the clinical trial process much more quickly, much more safely. So we will be able to bring a vaccine to bear more quickly. I'm highly confident of that. In the meantime, the tools that we have at our disposal are the tools that are available. And we would need to enact them. But we watch this very, very carefully. One of the reasons that I moved so fast on Portugal, despite the fact that lots of people were having a well-earned break, is that we have a precautionary principle when it comes to potentially vaccine escaping variants.
So it's not something, to be clear, that we expect, but we need to prepare on a contingency basis. You've said that there's a plan to develop vaccines,
yes,
so that they are effective.
Yes.
These other measures that you're talking about, these are lockdown, social distancing requirements, and all the rest of things.
We have, I come back to the point I made about the pandemic preparedness plan. Yeah. What really matters when you're in it is the capability.
Right.
The plan is always going to be written to a different pathogen because it's the nature of virology that your problem is going to be with a new disease.
But you've learned a lot, everyone's learned a lot through this. Is there a plan for this? Is it written down or is it in your head and in the heads of...
Well, we don't have a published plan, but we have, I think the best way to describe it is we have the playbook in front of us.
Given what we've learned and what you've said about the importance of transparency and being honest that we don't know all the answers or didn't know all the answers at the beginning, and we gleaned lessons from other countries, from our own practice, would it not be a good idea to publish the plan and to be explicit about it and to allow people to consider it, interrogate it, and perhaps make constructive suggestions around it? Wouldn't that give confidence?
I'll consider that. Set against that is the following, that vaccine escape is a relative, not an absolute concept. So we know that variants do respond differently to the vaccine, given that the current vaccines were all aimed at the original Wuhan strain. And so we know, for instance, that a single dose of either Astra, Oxford, or Pfizer is less effective in terms of reducing transmission on the Delta variant, but we know that a double jab is statistically insignificantly different. And therefore, there is a degree, if you could describe it like this, of vaccine escape of the Delta variant from one jab, but thankfully not from two. So vaccine escape is a relative concept, not an absolute one. So writing a plan for absolute vaccine escape is essentially writing a plan for a new pandemic. Because if there was a variant of the virus against which our current vaccines didn't work at all, then that would be essentially a new pandemic. And I think we are better prepared by a long shot for a new pandemic, both in terms of the physical capabilities that we have as a country, of all the things we've been talking about, and frankly, the intellectual framework for dealing with it, that many policymakers in the Far East had experience of and could bring to bear. And so both our policy playbook and the capabilities that we have are better placed. And so I'll consider it, but you can see my initial reaction is to think in the first instance, it depends on the degree of escape.
Well, a plan need not be a binary thing that just deals with one factor. In fact, it would be a poor plan that didn't consider a range of scenarios, and to have it in advance might have some advantages.
Yeah.
Thank you, Reverend. In your response to Taiwo, you wouldn't be drawn for reasons we understand on the Delta variant and the implications for unlocking, and there's a decision to be taken over the weekend. For those members, Parliament and members watching these proceedings, they might be interested to know that the Science and Technology Committee will be taking evidence from scientists on this on next Wednesday at 9:30. So we will have an exhaustive, and I hope not exhausting, consideration of that. But thank you for your evidence today. You've made some commitments to follow up in writing with some written evidence. I hope that you at least will be able to do that promptly.
Well, of course, and thank you and the whole committees, both of the committees, for giving me the opportunity to set out the facts and the truth. And if you have any further questions, then please do write, and I'll get back to them as soon as possible, because I know you want to publish soon. But for me, it was important, and I'm very grateful for the chance to be able to set out what actually happened, and I hope I've been as clear as I can be.
Secretary, it hasn't been 7 hours, but it has been nearly 4.5 hours. So we're very grateful to you for your time today, and that concludes today's session. Order.